Good afternoon to one and all. I, Dr. Raman Sharma, extend my warm welcome to our Executive Director, Major General Professor Atul Kotwal sir, Sena Medal, Vishisht Seva Medal, Dr. Jayan Srivastava sir, Advisor Quality and Patient Safety Division, NHSRC, Dr. Sangeeta Sharma ma'am, President DSPRUD, and to all the participants who have joined in this webinar. Having said this, I would also like to welcome our guest speakers for this webinar. Dr. Bhavuk Garg, Associate Professor, Department of Psychiatry, Lady Hardinge Medical College, New Delhi, and Dr. Tanmay Joshi, Assistant Professor, Department of Psychiatry, AIMS, Bhopal. Now I request Dr. Jayan Srivastava sir to please address the participants.
Thank you, Aman, and very good afternoon to all the participants who have connected from different states and the central government institutions. So at the outset, on behalf of Executive Director NHSRC and all the participants, and also on behalf of DPSRUD, we extend a very warm welcome to our two eminent guest faculty who will be talking on the two very pertinent, relevant issues: common mental disorders, substance and alcohol abuse. And just to give a bit of background that what is the context of this series. So basically this series was conceived and started about 2.5 years back with the sole intention of reaching out to the peripheral health facilities, the practitioners over there who are working in difficult circumstances, particularly in the primary health centers at the community health center level, where there are not many opportunities available for the cross-learning, keeping abreast themselves of the developments whichever is happening, at same time refreshing their knowledge. So in this initiative, our Executive Director, Major General Professor Atul Kotwal, have been the key driver, and of course Dr. Sangeeta Sharma remains one man army or one woman army, if I may say so. These two eminent medical education leaders have been, in fact, spearheading this initiative. But the mental health is one of the challenges on which have been, in fact, drawn the attention of the key policymakers during last 3 to 4 years or so, particularly when the outreach services are being taken to the doorsteps of the communities, to the families. And one of the critical element which are the part of the 12 service packages under the universal health coverage agenda is the mental health. We all know that there is a considerable stigma is attached, but now gradually the people are realizing the importance of asking for the professional education, professional help. And in that context, we chose that let's have these two common problems which all of us encounter in day-to-day our settings. And without much ado, without taking much time, because there are about 203 participants who are logged in, but I must inform and acknowledge that at many locations there is more than one participant attending the webinar through a common setting, because in the rural setup it is not possible that everybody individually logs on to the through individual laptop. So our actual participation, I would say, will be about 400 to 500. That is the kind of audiences we are having today. Our request to both the speakers would be just please delve into certain, say, primary healthcare level challenges. That would be extremely helpful. And a key message to all the participants, those who are connected, that please, like it has been happening in the previous sessions, whatever the queries, whatever the doubts you have, please post in your chat box so that our experts will be able to answer. And subsequently, there is and always, like Professor Sangeeta Sharma has always been conducting herself a session, and today also she will be talking. The third session will be taken by her. So I am stopping over here and requesting our Executive Director, Major General Professor Atul Kotwal, to deliver the inaugural address. Thank you very much.
Thank you, sir. Good afternoon, everyone. It gives me great pleasure to mention that this is the sixth session in the third series of STG lectures which we have been holding. And I must compliment Dr. J.N. Srivastava sir and the entire quality and patient safety team for organizing this, and Dr. Sangeeta Sharma, again, as I has already mentioned. And so it's really commendable. And I must commend all the participants who on Saturday afternoon attend these sessions, and take interest and ask questions and make it interactive also. Because the participants are the main for any kind of activity, and it means that there is some benefit. And as we all know, that the gap between clinical practice and knowledge of standard treatment guidelines, standard workflows, that impacts the quality of patient care. And so all of us, even after doing our degrees and our qualifications for a particular job, we need to attend such sessions to understand, as we evolve, the newer treatment modalities available, newer approaches to patients of particular disease. So that way, I think this series is benefiting, and that's why every Saturday we have such large number from all over the country. The doctors, the specialists, staff nurses, CHOs, ANMs, and even other allied healthcare workers also of our entire health setup of our vast and huge country. Really very happy to see such number of participants in every session here as such. And I'm told over the 12,000 healthcare professionals have attended till date all these sessions in the third of the series. So today's topic is very relevant and important. And if you see the magnitude, which I'm sure both the experts, Dr. Bhavuk and Dr. Tanmay, would be sharing with you. But just a recap that, as per WHO in 2019, this is 6 years ago, that's the document which we could get, that 1 in every 8 people, or over 970 million around the world, were living with mental disorder, with anxiety and depression being the most common. And common mental disorders contribute significantly to the global burden, and add the more than 50% of years lived with disability. So that's a major very serious consequence of mental health disorders. In India, as such, studies report that approximately 10%, 9.4 to 10% of the Indian population consumes alcohol, with a high prevalence among males compared to females. And alcohol, tobacco, and drugs and all also gateway, and also they are linked with the the common mental disorders. So this sometimes we call these as comorbidities. And the drug use is increasing, especially in the younger population now. Same goes with alcohol also. So and this, if it is linked with the poverty, violence, disability, inequality, so those ones are at higher risk to develop mental health disorders. And of course, there are certain biological and psychological and social factors. So all these interact in a very complex manner, and that varies from a person to person. So I'll not go into delve into this subject, because we had two experts, and followed by Dr. Sangeeta Sharma herself will be talking. But then, as you all are aware, this is important for us, because under comprehensive primary health coverage, saying CPHC, at the Ayushman Arogya Mandir level, the package of MNS, mental, neurological, and substance abuse, has been added. So all of us have to now start, whenever someone comes, even an adolescent who might visit the arm at subcenter or PHC level, or even CHC or DH level, might come with a toothache. But in reality, he or she would have come for, to see whether someone is able to understand me. He or she might have come with some kind of abuse at home, or in school, or in some by peer group, or some other stressors, or some other issues, mental health issues. But they might not most generally come with that I have this issue. So they might come with something else. So that's where our ability to, we have to interact with everyone. We have to understand their issues, their family issues also, And that is the only way they will have trust in us and they will start discussing their mental health issues with us. So we all know about National Mental Health Program, District Mental Health Program, and telemanus is something I think which we all must leverage now, and which is a large number of calls are taking place, and lot of examples from various states which states are sharing with us of benefit we people share after connecting to the telemanus call. So today's session, we have a talk by Dr. Bhavuk Garg, who's have been interacting with him regularly because he's part of various meetings in ministry also on mental health. So he'll be talking about management of common mental disorders. And he's a associate professor in Department of Psychiatry, Lady Hardinge Medical College. Next will be by Dr. Tanmay Joshi, who's the assistant professor, Department of Psychiatry, AIIMS Bhopal, regarding early intervention of alcoholism, drug addiction, and substance abuse. And in the end, the session by Dr. Sangeeta Sharma, who's professor of neuropsychopharmacology, ABHAS, Delhi, and also president of DSPRUD, and rightly said by Dr. Srivastava sir, one woman army behind this thing, along with Dr. Srivastava and his team. And she'll be talking about profile of medicines used in psychiatric disorders, because drug use also has to be, very, very appropriate in this. So we aim to have, these discussions every Saturday to enhance understanding of strategies and all for diseases. And today it is for understanding this and managing common mental disorders, early intervention of substance abuse, and in fact, I generally use another term, which is substance use and misuse. The psychiatrists both present here, we can discuss later what substance abuse is generally being used. So drug addiction, substance abuse, and all. And going further ahead, we have to start looking at the neurological part also in MNS. Today we are focusing more on mental and substance S, M, and S part. N part is something which is not given due importance right now, but again, there are examples from Karnataka where since NIMHANS is there, and that will also come in gradually, how the neurological this thing can also be looked at, to look at the dementia and Alzheimer's and all, how we can prevent those and how we can manage. But today we'll be focusing more majorly on mental and substance abuse as such. So I wish all the large group of specialists, doctors, CHOs, staff nurses, professionals of other different disciplines and all to get a benefit from this. And please be interactive. Please keep asking questions in the chat so that those can be answered by experts. And even later, if you recollect something later, or if you find a challenge sometime in your practice, feel free to drop in a message to the QPS team. They'll be very happy to reply to, interact with you and try to resolve your queries. So thank you very much. Wish you all the very best.
Thank you so much, sir, for your kind words. With this, I would like to invite the first speaker for today's session, Dr. Bhavuk Garg. As already told, sir is an associate professor in the Department of Psychiatry and Drug De-Addiction Center of the Lady Hardinge Medical College, New Delhi. Sir is also associated with the mental health division in the DGHS, Ministry of Health and Family Welfare. With over 14 years of experience, his special interest spans around community psychiatry, forensic psychiatry, and child psychiatry. He has publications for more than 25 in various national and international journals. Also awarded by A.K. Kala Award by the Indian Psychiatry, and also received fellowship under the Indian Psychiatric Society. Sir, over to you for your session. Thank you.
Thank you very much, and special thanks to Kotwal sir and Sangeeta ma'am for giving me this opportunity to interact. And this is one topic that is very close to my heart, especially the target audience that we are looking at today. And Kotwal sir has already set the base for my lecture, that as part of the comprehensive primary healthcare package, mental health, neurological, and substance use disorders are also something that we are focusing a lot on, because that is something that we feel that can be managed at the level of the community and can reduce the burden at the secondary and the tertiary level of healthcare. So I'll just share my presentation. Okay, I hope my presentation is visible.
Yes, sir, it is.
Okay. So before I start, let me just put in a few disclaimers or a few points towards the audience. That it's not expected that the audience will become well versed with psychiatry in just one session. It took me 3 years at least to understand psychiatry, but the main target of such a session is to sensitize the various with the various people involved in this field to identify mental health issues, to know when to refer, and also to manage them at the level where it can become manageable and be referable. Right. Secondly, I'll take this opportunity in this session to discuss a few points about the public mental health setup in our country, in India, so that one has an idea where the patient needs to be referred to. I'll be primarily trying to make you understand the mental health, what mental health means and what mental disorders are, and the various referral areas and the resources that are existing in our country. And as this session is being planned by NHSRC, it goes without saying that NHSRC has been instrumental in formulating the operational guidelines for the various packages under the Ayushman Comprehensive Primary Healthcare MNS package, being one, mental health neurological substances. And I'll urge all the participants to go back and read. They are available on the website of NHSRC to read those manuals. They are very informative, and they'll, I think, cover most of the aspects that I'm going to talk about. Further, there is also the standard treatment guidelines which are already existing, and Sangeeta Sharma ma'am is the lead author of those guidelines. So I'll request all the participants to go through those guidelines. The secretary part is also well written in that. And the third important resource for you guys would be the ICMR standard treatment workflows, which I'll be referring in my presentation to how to deal and go about the algorithm of common mental disorders. So before I start, and I usually start my sessions with, if they are, I don't know if the audience have the ability to speak up or put things on chat, but please do if you can, otherwise I'll tell you the answer. So mental health has been a focus of many movies, and I'm a movie buff myself. So there are some movies, I don't know if you know, in Hollywood, we have the movie Shutter Island, The Aviator, A Beautiful Mind, As Good as It Gets, One Flew Over the Cuckoo's Nest, and Silver Linings Playbook. So Shutter Island gave a good depiction of schizophrenia. A Beautiful Mind also gave a good description of schizophrenia, which is severe mental disorders. Aviator and As Good as It Gets talked about obsessive compulsive disorder. Silver Linings Playbook was about bipolar disorder and borderline personality disorder. And very important landmark movie, One Flew Over the Cuckoo's Nest, which gave a very negative portrayal of electroconvulsive therapy, or treatment which we psychiatrists commonly use. So if anyone is interested and not seen, please go and see these movies. Near to home, Dear Zindagi, I hope everyone has seen, gives a very good portrayal of how non-pharmacological treatment works in mental health. So good account of psychotherapy or psychological therapy. Bhool Bhulaiya, very good depiction of dissociative identity or split personality disorder, as it is commonly known as. 15 Park Avenue, again a good depiction of schizophrenia. Karthik Calling Karthik, again about schizophrenia. And Tare Zameen Par, very landmark movie, raised a lot of awareness about dyslexia, or what we call a specific learning disorder in our psychiatric parlance. So please go back and watch these movies if you haven't watched yet. So what is mental health? WHO, World Health Organization, gives a very nice definition of mental health. And all the components are quite important. It's a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. So it's not just the absence of any symptoms or signs. It's mainly about that a person can manage daily stresses of life and work productively and contribute to the society. So if a person is able to do all these, then we say that a person is mentally healthy. On the other end, what does a mental disorder mean? There are different classificatory systems available for mental disorders, but the common theme for establishing a mental disorder, whenever a patient comes to me or a person comes to me, I look at these four things to say that the person has a mental disorder or not. So the first would be deviance, which means the specific thoughts, behaviors, or emotions that are considered deviant or different or unacceptable to the society. If someone is feeling having low mood, or someone is angry, irritable, but just having deviance is not enough. There should be distress. The person himself or herself should be distressed by these symptoms or the deviant thoughts, behaviors, or emotions that he or she is having. There should be, very importantly, dysfunction, and this dysfunction can be socio-occupational, which means that the person is not able to interact socially, not able to go out of the house, not able to interact with others, as well as perform his daily activities of living. सामाजिक और व्यवसायिक जीवन पे दुष्प्रभाव पड़ता है in mental disorders. And in case of children and adolescents, there'll be dysfunction in terms of their academics and school and college functioning. And lastly, dangerousness. The individual is quite dangerous or violent, and the behavior can be directed to the individual himself or herself or the other. The person may be suicidal or aggressive towards the others. So only if psychiatric or psychological symptoms are present for a significant duration of time, and if they are causing distress and dysfunction, only then we call it as a mental disorder. Otherwise, we do not diagnose as mental disorder. This is very important because nowadays any kind of psychological distress is being equated to mental disorder, which should not be done. Kotwal sir mentioned about this, the basis of mental disorder. So we have what we call as a biopsychosocial basis to mental disorders. It's a combination of biological factors such as the neurochemistry, metabolic profile like obesity, diabetes, genetic vulnerability, immune response, the physical health, any comorbidity the person may be having. Then we have the social factors which interact, peer group, work and school environment, socioeconomic status, the cultural factors, the family situation, and the psychological aspects, the self-esteem, coping abilities, how the individual perceives about the others and the environment, the temperament, the social skills, attitudes, and beliefs. So this Venn diagram that you see on the right of your screen, it gives a very good depiction of the overlapping and the different factors, the biopsychosocial basis, how they interact together and lead to mental disorders. So any kind of management that we do is also directed towards these three aspects. So biological, we try to target through medications. The social aspect, we tend to look at the family and the environment, and in certain cases, we may also do family therapy. And the psychological aspect, we target through psychological means or psychotherapy. There are certain common myths about mental illnesses, which I think the various CHOs, the nurses, and the ASHAs, the frontline workers, if they're attending this session, they should be aware of, because we need to dispel these myths within ourselves as well as in the community that we work in. So mental illnesses aren't real illnesses; they are as real as any other biological illness like diabetes, hypertension. They will never affect me. They can affect any person, how strong a person may be. It can affect any person of any age, of any gender, race, caste, color, creed, etc. They are an excuse for poor behavior. It is not so. They are very real symptoms and which have a biological basis, and they have been well described in the literature. Bad parenting causes mental illnesses. Not so. It's nothing to do with any past sins or any past wrongdoing that a person may have had, or parenting which may have been an issue. So it doesn't cause mental illness on itself. It's like I mentioned in the previous slide. It's a biopsychosocial basis. People with mental illness are violent and dangerous. The studies have shown that the rates of violence in mental disorders is not significantly higher than the general population. People don't recover from mental illnesses. Again, the treatment is quite advanced now, and we are able to lead to complete resolution of symptoms, and the person is able to lead a normal life on treatment if they are suffering even with severe mental disorders. People of mental illness are weak. Like I mentioned, it's nothing to do with your strength, or it does not reflect any kind of weakness. Kids can't have mental illness. So children and elderly, geriatric population, both can have mental disorders. In fact, in elderly, the rates of certain mental disorders can be higher as compared to the adults or the young adults. All patients require medication. Again, many patients, like I'll mention in the forthcoming slides, having mild symptoms can be managed on psychological treatment or psychotherapy alone. Medications are addicting, they go on for life, they make you a zombie. Again, currently, most of the medications that we prescribe are not addicting, they are not habit forming. In many cases, we are able to stop them after a course of 6 to 9 months or 2 years, and they do not make you a zombie, they do not take away your feelings. You are able to, in fact, lead a better and a more productive and functional life if you take medications for mental disorders. So this is the broad classification of mental disorders. They are broadly divided into CMDs or common mental disorders and severe mental illnesses. I'll be talking about the management of CMDs. So CMDs largely consist of, they are more prevalent, less disabling, and often treatable with on OPD basis. And again, at the community level, these are the ones which can be managed right at the community. So depressive disorders like major depressive disorder and dysthymia, anxiety disorders like generalized anxiety disorder, panic disorder, social anxiety, phobias, and obsessive compulsive disorder, and somatoform disorders. SMIs mainly consists of psychotic disorders like schizophrenia, bipolar disorders, and severe depression with psychotic features. This table that you see, it's not as per ICD-11 or DSM-5 TR, the classification system we use. I have just provided a brief overview to all of you so that you are able to understand the distinction between common mental disorders and severe mental illnesses. Right. So just a brief word about the public mental health setup that we have in our country, and it gives me immense pride to tell you that if we compare it with the other countries, India has a very robust public mental health setup, and we have a national mental health program. I think many of the participants are from SPOs or the from the mental health program as well. So NMHP is ongoing since 1982. It's a very old program, and India has its own national mental health policy, its own Mental Health Care Act. It's the Rights of Persons with Disability Act is also very heavily grounded in the disability aspect and covers the mental health aspects as well. So we have a robust legislative as well as executive framework of mental health. Under the National Mental Health Program, we have the District Mental Health Program, which is currently approved as on date for 767 districts, in which a very dedicated team, a multidisciplinary team is available at the level of district hospital, which also carry out outreach activities in terms of service delivery, clinical service delivery, as well as awareness activities. We have the tertiary care component, the manpower development scheme, under which many medical colleges and other institutes of eminence are provided funds for infrastructure as well as to recruit faculty and start courses in psychiatry, clinical psychology, psychiatric social work, and psychiatric nursing. As of now, we have 25 centers of excellence under Scheme A and 47 PG departments under Scheme V, which are getting support from the Ministry of Health and Family Welfare. And most importantly, we have the National Telemental Health Program, which is now in its third year, the Telemanas. Very importantly, we all should remember the number of Telemanas, that is 14416. It's a number we should all remember, and we should always tell to our patients, the community, our friends, that this is one number which is 24/7 available to provide mental health services. The Telemanas cells have now been established as of date in 51 sites across the country. In addition to this, we have the comprehensive primary health care, the CPHC package, right at the level of the sub-center, now known as Ayushman Arogya Mandis. Out of the 12 packages, we have a separate dedicated package for mental health, neurological, and substance use disorders. And like Kotwal sir rightly mentioned, in this M&S gets covered, sometimes the neurology part gets ignored or left out. So I'll urge the organizers to maybe plan one session on neurological aspect as well in the forthcoming series of lectures. In addition to this, at the level of the tertiary healthcare, we have state mental hospitals. Around 40 mental hospitals exist in the country, one in every state, nearly in most of the states. We have the psychiatry departments of medical colleges and institutes of national importance, that is AIIMS and NIMHANS, Bangalore. And we have the Central Government Institutes of Mental Health, which is CIP Ranchi, Lokpriya Gopinath Bodoloi Regional Institute of Mental Health, Tezpur, and NIMHANS, Bangalore. So, like I mentioned, the mental health setup spans from primary level to the secondary to the tertiary level of healthcare. So, coming on to the topic per se, after this brief background, standard treatment workflows. I'll just request the organizers if I am on time or if I should be rushing up a bit. Organizer, is my pace okay?
Yeah, it's
Yes, sir.
okay. We have time up to 5:30, and we are 3 speakers, so I think you're well on time.
Right, ma'am. Okay, thank you. So we have multiple documents available which tell us how we can manage common mental disorders. So, like I mentioned in the beginning, we have the standard treatment guidelines (STGs), which are, I think, if I'm not mistaken, published by Walter Kluwer, and Sangeeta ma'am is one of the lead authors along with Dr. Sethi. Again, he was also my teacher at Maulana Azad Medical College. And we have the NHSRC manuals, MNS package, that also very beautifully and in a very nice flowchart manner gives a very comprehensive account of managing the various common mental disorders as well as substance use and neurological disorders. And most recently, which I will be referring in my presentation, the Indian Council of Medical Research, ICMR, with a series of experts, has come out with standard treatment workflows for various mental disorders. So I've borrowed the following slides from their standard treatment workflows, and they will give a very up to date and a beautiful description of how to approach and manage the common mental disorders. So we'll first start with one of the most common mental disorders that we see in the community level is that of depression. Like Kotwal sir mentioned, around 1 in 10 persons have been found. The studies show that more than 1 in 10 persons have depression, and if we take into account subsyndromal depression, the figure comes out to around 1 in 4 or 1 in 5. And we have a very significant treatment gap of around 60 to 70% of mental disorders. Only 3 out of 10 people are able to seek mental health services for their mental health issues because of multiple factors like stigma, lack of awareness, and most importantly, the lack of trained mental health professionals in the country. We have a very huge shortage of psychiatrists, clinical psychologists, and psychiatric social workers and psychiatric nurses. Herein comes the role of the audience that we are having today, the various CHOs, the primary healthcare physicians, and the other members involved in the community healthcare service delivery. If we are able to uh, empower you to recognize the mental health issues and recognize when to refer and the what basic treatment can be given at the level of the community itself, will go a long way in overcoming the treatment gap that we talk about. So in depression, we have the core symptoms of depressed mood, loss of interest and enjoyment, and easy fatigability. These are the 3 core symptoms. And there are certain additional symptoms: reduced concentration, self-esteem, ideas of guilt and unworthiness, pessimism about the future, ideas or acts of self-harm or suicide, disturbed sleep, or reduced appetite. And to make a diagnosis, I mentioned in the beginning slide, duration is very important. So they should be present for at least 2 weeks, and they should lead to distress and dysfunction. And depending on the number of symptoms that a person may have, we classify and categorize it into mild depression, moderate depression, and severe depression. Clinical assessment primarily consists of looking at the cognition. Cognition means the thinking about low mood, and the cognitive symptoms of helplessness, hopelessness, and worthlessness, negative views about the self, about the future, and about others in your environment. And a very important aspect of any mental health assessment is assessing suicide risk. And there's a very common misconception or myth that asking about suicide risk increases the suicide risk. Studies have clearly shown that, and our clinical experiences also endorses that asking about suicide risk to a person does not increase suicide risk. It actually helps us find persons who may have suicide risk so that we can take necessary steps to manage that risk. Suicide is something which is preventable and can actually prevent a life from being lost. So we have to assess about suicidal thoughts. वेरी सिंपली वी आस्क, आपको किस तरह के विचार आते हैं? क्या आपको कभी ऐसे विचार आते हैं कि खुद को नुकसान कर लूं? Sometimes the patient may have passive death wishes, that I do not want to kill myself, but sometimes I have thoughts that something happens to me. God takes away my life, or I end up into an accident. If I sleep, I don't wake up in the morning. So people may have passive death wishes, or they may have active suicidal thoughts that I want to kill myself. Sometimes they may have plans that I want to use a rope to hang myself from the fan and commit suicide. So depending on if the person is having suicidal plans, we rate the suicide risk as significantly high, and in such cases, inpatient psychiatric treatment is advisable. In all cases, also assess for friend and family support. In our country, the availability of family is a very huge positive, and we should identify and use that support that we have from the family as well as the community wherever it is applicable. There may be some investigation that may be required, like thyroid function test, complete blood counts. Anemia can have presentation as depression. Hypothyroidism can also present as depression. We should rule out certain medications which can be contributing to depression. Very commonly, beta blockers like propranolol, atenolol, they contribute to depressive symptoms. Persons, PL-HIV persons who are living with HIV on antiretroviral drugs, certain antibiotics, they are associated with depressive symptoms. So a good history can help us rule out contributory factors towards depression. So after we have diagnosed and assessed and rated the severity, so mild depression is something which can be easily managed at the level of primary care, that is the sub-center and the primary healthcare level. So consists of advice to the patients to modify their lifestyle, use techniques of behavioral activation, involve in the community, carry out some physical activities like yoga, pranayama, meditation, and physical exercise as well. They are known to increase endorphin levels and reduce the depressive symptoms. Monitor your activities, write down your activities, make a catalog of your thoughts, focus on your values, express gratitude, uh, and by the community CHOs, they can provide brief counseling or supportive psychotherapy. Validate the problems, tell them that yes, we understand this is a problem. Just dismissing them, कुछ नहीं होता, सब गुजरते हैं इस दौर से, बाहर आ जाओगे, हंसो खेलो खुश रहो. Such advice usually does not work. So understanding and validating their feelings is very important while you're dealing with depressive symptoms at the level of primary care. If no improvement in 4 to 6 weeks, then one should consider pharmacotherapy. So in mild depression and moderate, usually we start with, I think your pre-test, I went through a pre-test. Pre-test covers some of these aspects. So maybe after this, you'll be able to score higher on the post-test if not done in the pre-test yet. So we have certain medications. Most commonly, we use SSRI, selective serotonin reuptake inhibitors. In the last session, I'm sure ma'am would be touching upon these. So the first line medications are usually escitalopram and fluoxetine, which have the least side effects, but other agents like sertraline, fluvoxamine, citalopram, and paroxetine are also available. In the initial period, we sometimes also prescribe low-dose benzodiazepines like clonazepam for sleep disturbance and anxiety symptoms. And one should usually wait for 2 to 4 weeks for the SSRIs to show their effect and not be hasty in changing the medications. And if the person responds, the treatment should continue for 6 to 9 months in case of the first episode, after which it can be tapered and stopped. If multiple episodes, then the treatment duration can last longer. When one should refer to secondary care, if you are finding difficulty in making a diagnosis, if there is no improvement on pharmacotherapy after 4 to 6 weeks, in case of special populations like elderly, pregnancy, lactation, children, and adolescents, if there comorbid medical illness and substance use, and if there is suicide risk. So in such cases, one should refer to secondary care, where again the broad management plan would be SSRIs, selective serotonin reuptake inhibitors, and in case of no response, sometimes we also give tricyclic antidepressants, but very cautious with use of TCAs, because TCAs carry with it themselves a risk of overdose, which can lead to epileptic fits, seizures, and arrhythmias. So usually at the level of primary care, we do not recommend using tricyclic antidepressants. In case of non-response, we can shift to other medications like serotonergic and noradrenergic reuptake inhibitors, SNRIs like venlafaxine, and there is another category known as NASA's, noradrenergic and specific serotonergic agents like mirtazapine. Cognitive behavioral therapy, CBT is something which will require a trained clinical psychologist, so it will be available at the level of secondary and the tertiary level of healthcare. Add-on yoga therapy and meditation is always recommended. In cases of when to refer to tertiary care, if no improvement of second line treatments, immediate risk of suicide attempts, need for intense counseling or psychotherapy, and comorbid substance, polysubstance, and cannabis. So special population like pregnancy and lactation, sertraline is one of the agents. We usually prefer psychotherapy in pregnancy and lactation, but if medications become important, sertraline is the drug of choice. It has the least passage through the placenta as well as the breast milk. In elderly, we use sertraline and escitalopram. The reason being that these two drugs have minimal drug-drug interactions with other medications. Elderly population is very commonly receiving other medications for diabetes, hypertension, etc. So these will have minimal drug-drug interactions and they are pretty safe in terms of the cardiac status and diabetes as well. In elderly, avoid agents like tricyclic antidepressants. And very importantly, again, very important for the secondary level and the primary level people, that SSRIs in elderly, they can cause hyponatremia. And very commonly, we find that elderly people are having cognitive symptoms, or they may be having delirium, confusion, or disorientation. And SSRIs may be a contributory cause towards that. Tertiary level healthcare, I'll not go into specifically, but one point I would like to make, that in case of suicidal patients and presentations like catatonia, treatment options like electroconvulsive therapy given under the effect of anesthesia is very, very effective. So one should not be scared of a treatment modality like electroconvulsive therapy. It's pretty safe and pretty effective. Second group of disorders is anxiety disorders. Do we take a break to take any questions, or I continue, ma'am?
Sir, you may continue, sir.
Right.
We'll take questions at the end.
Right. Okay. So second group is of among common mental disorders, anxiety disorders. Broadly, we'll have symptoms like tension, anxiety, apprehension, fear, and worrying about every little thing. There can be associated sadness, lack of interest, and negative thoughts. Very commonly, we can have physical symptoms. Again, Kotwal sir very nicely mentioned that a child may be coming with repeatedly with toothache. It can be just an indicator of underlying mental health issue, and we are not able to find any organic basis or actual pain in any cause in the tooth for that pain. Physical symptoms like chest pain, abdominal pain, muscular tension, headache, and nausea can also occur in anxiety disorders. There can be episodes of palpitations, racing of heartbeat, difficulty in breathing, feeling of choking, lightheadedness, dizziness, fainting, and trembling. This we very commonly see in panic attacks, and very commonly patients present to us with a feeling of impending doom. And in emergency setting, these present as suspected myocardial infarction or heart attack. The ECG comes out to be normal. The age is not matching a young adult coming with this presentation. Panic attacks need to be considered as a differential diagnosis in such cases. Attacks of fear, losing control or going crazy, or fear of dying. And lastly, repeated unwanted thoughts, images, or impulses, which is an obsessive compulsive disorder. Classically, OCD has been considered as an anxiety disorder, but the recent understanding categorizes OCD as separate from anxiety disorders, but it does come under common mental disorders. So diagnosis of generalized anxiety disorder would be on the basis of chronic feeling of tension, apprehension, anxiety, or worrying about a number of events that involve everyday or routine circumstances like work, school, health, finance, etc. In agoraphobia, there is fear of going out, fear of crowded places. The person becomes incapacitated, homebound, and home restricted. They avoid using public transportation like trains, buses, planes, etc. Panic disorder, there are recurrent unexpected episodes of panic attacks. In social phobia, there is marked fear avoidance of social situations like meeting a senior, meeting a group of people, not able to speak on the stage, not able to interact in a group setting. And lastly, obsessive compulsive disorder, where there can be repetitive, unwanted, intrusive thoughts, images, or impulses. The thoughts can be about dirt or contamination, harming oneself, sexual thoughts, blasphemous thoughts, negative, wrong thoughts related to gods. And there are repeated behaviors like repeated hand washing, checking doors and locks, arranging things, etc. So the assessment would consist of the duration of anxiety, the degree of distress and impairment in day-to-day functioning, comorbid symptoms of depression, substance use, and we have to rule out physical disorders like thyroid dysfunction, uh, adrenal tumors like pheochromocytoma, which present with panic attacks, and very commonly hypoglycemia also presents with as a panic attack. We also need to assess the psychosocial factors, like I mentioned. Mental health disorders are biopsychosocial disorders. So psychosocial factors like ongoing stress and issues in workplace or at family or in school, etc. So management, again, primary, secondary, and tertiary care level. At the primary level, reassurance and psychoeducation that it's okay to have these symptoms. These symptoms are quite common, and these symptoms get better, and they will not lead to anything untoward or anything sinister happening in the future. Do not investigate excessively. In certain cases, as per the age and the presentation, ECG may be necessary. Discourage doctor shopping. Very importantly, exposure is very important. A simple tip that can be given at the primary level: if you have a fear of certain thing and if you have a phobia, one should not avoid those situations. One should gradually start facing those situations, which is the basis of exposure therapy that we use for phobias and anxiety triggers. In obsessive compulsive disorder, again at the primary level, we can educate it that unwanted thoughts are a part of illness and are not a reflection of character or hidden intentions. In mild cases, medications may not be required. If no improvement, if the symptoms are persisting, we can again, the drug of choice and the first line of treatment is selective serotonin reuptake inhibitors or SSRIs. We can give escitalopram at doses of 5 mg, which is optimized to 10 to 20 mg per day. In cases there are physical symptoms are very significant, then we can give benzodiazepines like clonazepam and lorazepam. But very importantly, benzodiazepine should not be continued for more than 2 to 3 weeks, because out of the various medications, these are the medications which have the potential for causing addiction or habit forming potential. Monitor for side effects on SSRIs like sexual dysfunction, sedation, or weight gain, and monitor and address them periodically. In case the symptoms are not improving, there are significant comorbidities, or the symptoms are severe, they should be referred to the secondary level of healthcare. The treatment again consists of sertraline, fluoxetine, paroxetine. In OCD, there is a specific agent, SSRI fluvoxamine, which is very effective. Add-on cognitive behavior therapy is very, very important in such cases. And if it's not manageable at the level of secondary care, or if it's not responding to treatment, then it can be referred to tertiary care, where again further medications like can be used. I'll not go into details of medications at tertiary level of healthcare. Primary and secondary very important. And just to tell you that under the comprehensive primary healthcare package as well as the district mental health program, most of the medications that I have been talking about, they are available at the level of sub-center and the primary health center, as well as the CHC and the district hospital level. And I'll come to that later. One of the important measures is that if the medications are prescribed by the medical officer at PHC or the trained psychiatrist at the level of district hospital, the patients can be dispensed these medications by the CHO at the level of sub-center when the patients are stable. They need not travel far distances to the district hospital to just get a refill of their medications. So this is a provision that has been provided in the comprehensive primary healthcare package. Lastly, we have the somatoform disorders. Very common presentation, but very difficult to diagnose. Patients have repeated subjective experience of physical symptoms which are not explainable by any recognizable physical disease. Bodily complaints are very common. Patients usually ask for repeated investigations. They don't get reassured after normal investigations, or if the doctor tells them there is no physical basis to it. There is doctor shopping. They keep on visiting different doctors, and they keep on having repeated visits to the centers as well. Presentation can be in terms of pain at multiple body sites, fatigue and exhaustion. There can be functional disturbance of different organ systems like repeated constipation, diarrhea, pain in chest, pain in abdomen, headache, etc. And the focus of the patient is more on symptom relief rather than the cause of illness. So they are also known as medically unexplained symptoms or somatization disorder. Assessment to rule out any physical basis to it, a detailed history, physical examination, and investigations if required. Psychosocial assessment is very important in such cases. Very commonly in somatoform disorder, we find that there are underlying family issues or psychosocial stresses like problems at workplace, problem with friends, a breakup maybe. So these are very common presentations of somatoform disorders. Lower right column, list of common symptoms: abdominal pain, back pain, chest pain, dysmenorrhea, dysuria, pain in urination, gastrointestinal symptoms, regurgitation, vomiting, nausea, skin itching, burning, tingling, numbness, sexual complaints like erectile dysfunction, irregular menses, menorrhagia are quite common presentations in somatoform disorder. Treatment: low dose of antidepressants are useful. Here we commonly use tricyclic antidepressants in low dose, or antidepressants with noradrenergic mechanism. I mentioned SNRIs before, serotonergic and noradrenergic reuptake inhibitors. A medication by the name of duloxetine is very effective in such presentation. At the level of tertiary care, other agents like pregabalin, gabapentin are also available, but these are best used by specialists, and I would not recommend use of these medications at the level of primary or even secondary level of healthcare. Again, goes without saying, in all the common mental disorders, add-on yoga and meditation and pranayam are also very, very effective treatment modalities. Okay, so this was about the management of common mental disorders that we do at the level of different levels of healthcare: anxiety, depression, and somatoform disorder. Among anxiety, the various categories of generalized anxiety, panic disorder, and obsessive compulsive disorder, social phobia, and agoraphobia. So I hope that after this, one would be able to recognize the presence of these disorders, provide initial reassurance, psychoeducation, if you are competent enough and trained enough to prescribe medications, and also know when and how to refer, and very importantly, where to refer. That was my purpose of showing the public mental health setup, that you should be aware where to refer. And you should actually sit and map out your nearest district mental health facility, the nearest medical college from your place of practice, as well as the nearest outreach clinic that the DM district mental health program may be having, so that we do not end at just identifying. We have to close the loop. We have to refer them. And lastly, the CHO should be competent and confident enough to dispense these medications in case of stable patients who are prescribed these medications from the higher levels of healthcare. So again, the Indian public mental health setup takes care of all these things. It's for us now to implement these things and reduce the treatment gap that exists in mental health, the huge treatment gap that exists in mental health. So just very briefly about the comprehensive primary healthcare, because as I believe we have many people joining from the primary healthcare setup, and also from the secondary and tertiary healthcare setup, you should also be aware of comprehensive primary healthcare. I speak to many of my colleagues at medical colleges. They are also not very aware about that we have a very robust comprehensive primary healthcare package under the Ayushman Bharat program. So in the comprehensive primary healthcare, we have the framework at the level of community, the frontline workers, the MPWs, the CHOs, and the ASHAs. They provide community mobilization, health promotion, awareness activities, awareness about yoga, balanced diet, exercise, sleep hygiene, screening and detection of mental health issues using as part of CBAC form administered by ASHA, and also spreading awareness in the family and following up with the patients in the community who may be having mental health issues. At the level of sub-center, we have again awareness and stigma reduction activities, deliver psychosocial interventions, identify and screen for MNS conditions, and refer to higher centers. There are certain screening tools made available at the level of sub-center, which you can refer to in the MNS package that I mentioned, taken out by NHSRC. At the primary healthcare, we have a medical officer who delivers the services. If the medical officer is trained in mental health, they can provide treatment, medical pharmacological treatment for mental health issues. Especially, we expect that common mental disorders can be managed at the level of primary healthcare. And they should know when to refer to higher level of healthcare, that is secondary and tertiary level healthcare. At secondary and tertiary care facility, we will have trained medical officer or psychiatrist who will be able to provide comprehensive mental health services. We may also have clinical psychologists and psychiatric nurse at these levels of healthcare. So the frontline workers, they should conduct awareness activities, use tools for initial screening of MNS conditions, provide basic interventions, and refer positive cases to the Ayushman Arogya Mandirs, and carry out home-based follow-ups for persons to ensure that treatment adherence and continuity of care is maintained. It is very important. Persons with mental health problems, they frequently stop their treatment because of multiple myths and misconceptions. So the frontline workers, because they are nearest to the community, they are the best persons to follow up with these patients in the community and ensure that they are adherent to their medications. At the level of Ayushman Arogya Mandir, the CHO screen using the screening tools, offer basic interventions, and refer severe cases. They manage epilepsy and dementia cases and dispensing the medications for the MNS conditions. At the level of primary healthcare, diagnose and provide pharmacological treatment for common mental disorders, severe mental disorders, substance use disorders, and children and adolescent mental health disorders. Again, if you at the primary health care, if you feel that you are not competent or trained enough, you should always refer, and also take use of the hub and spoke model, which has been, I think, implemented in many states now, that using the e-Sanjeevani, you can interact with the nearest psychiatrist over a video call using e-Sanjeevani, and then the person can take treatment, initial treatment, and the treatment can be initiated. Also integrate horizontal integration with other programs looking at wellness, like Rashtriya Bal Swasthya Karyakram and Rashtriya Kishore Swasthya Karyakram for children and adolescents. For common mental disorders, specifically, we have the CBEC form. We have items for alcohol use, epilepsy, dementia. There are 2 questions for depression in the CBEC form, the PHQ2, Patient Health Questionnaire 2, which can help the ASHA screen for mental health MNS issues and refer to the CHO at the level of subcenter. At the level of subcenter, community health officer can use the SRQ 20 self-reporting questionnaire to identify common mental disorders, and PHQ 9 to screen for depression. I'm not going to details of these tools, please. At the level of PHC, very good. These 3 golden questions are mentioned in the manual by NHSRC. Feeling sad, worried, or anxious, disturbance in sleep and appetite, recent change in behavior. So these 3 golden questions every medical officer should ask with every patient to screen for mental health issues. Maybe it's a 6th vital sign after the 5th vital sign being pain, and 6th vital sign asking about being sad, worried, or anxious. These are the algorithms which are available in the NHRC manuals. Please go through these manuals, very nicely made manuals, which will help you identify both common mental disorders, substance use, as well as severe mental disorders, and also help you manage common mental disorders right there at the level of the community. Again, for depressive anxiety and somatization disorder, the common mental disorders, very nice flowchart of managing these at the level of primary health center. I'll just skip this. So this is something as part of one of the pilots is being done by the NHM in certain states. They have taken out this simple tool to screen for MNS conditions at the level of community by ASHAs, ANMs, MPWs. Questions about depression, anxiety, sleep issues, severe mental disorders, alcohol, tobacco, epilepsy, as well as dementia. So 6 questions, and if yes to any of the question, refer to CHO. CHO would then use certain tools like, please don't get troubled by this flowchart. I'll just tell briefly that at the level of CHO in the primary, at the subcenter level, there are tools like PHQ 9 for depression, GAD 7 for anxiety disorders, and audit for alcohol use disorder. To assess and screen for these issues and refer to the specialist or the medical officer at PHC in cases which are screened positive. And there is this module of managing emotions and symptoms of anxiety at the level of CHO, taking care of your body using yoga, exercise or walk, sleep, take care of diet, drink water 10 glasses a day, mindfulness and meditation, connect with family and friends, express gratitude. Spirituality is something which is also has been shown to have evidence in managing common mental disorders. Take care of your surroundings. So all these simple measures can help manage symptoms, especially mild symptoms of depression, anxiety at the level of the community itself. Referral is very important in cases of suicidality, violence, non-adherence to treatment, side effects to treatment, no improvement, worsening of symptoms requiring second opinion, and comorbid substance use. At all levels, Telemanas 14416 number is very, very important. Services are available 24/7. Otherwise, refer to the nearest medical officer or the DMHP psychiatrist or the psychologist. Family intervention, look at the family as well, provide support to the family, mobilize support from the family as well in cases. Just skip this. Right. Thank you very much. I'll end my talk here. Thank you.
Thank you, Dr. Babu, for sharing the entire, actually teaching psychiatry, that too in 30 minutes time is quite difficult. but I think he had made a very good attempt and gave you the entire spectrum of illnesses that we encounter. We have one or two questions here in the chat box. Let me ask you, would you be staying till the end of the session, or
Ma'am, I'll answer the questions now if it's okay.
okay. So very quick questions. How to differentiate between low profile lifestyle and depression?
That I touched in my first slide. Very important question, and this is one question that I always say should be answered. In terms of that, say first is presence of symptoms. The symptoms should be there. A constellation of symptoms should be there. One or two symptoms: feeling low, lack of concentration. So number of symptoms should be there. We should have 3 or 4 set of symptoms that should be there to make a syndrome. Most importantly, they should be present for a significant duration of time. See, we all feel sad in a particular day. If my boss scolds me in the morning, throughout the day I'm feeling sad, right? So and if I apply a screening tool at that time, I may screen positive and someone may call me as having depression, but it's not so. So those symptoms should be present for a significant duration of time, that we say for 2 weeks at least for depression, and they should cause distress and dysfunction.
Yeah.
उसकी वजह से आप परेशान हो रहे हो और आपके सामाजिक और व्यवसायिक जीवन पे असर पड़ रहा है. आप पहले शादी पार्टीज वगैरह में जा रहे थे, बट अब आप सोचते नहीं, मैं नहीं जा रहा, let me not go, I'll better avoid going to such a situation. Or you would take more time in finishing a task which you would finish earlier in a lesser time, or you would make mistakes in your work. So symptoms for a period of time causing distress, dysfunction, and present for a specified duration of time. Only if these are met, then we should diagnose as having any mental disorder or depression, and then we should offer treatment. Otherwise, we should not label any person with mental health issue just by mere presence of certain symptoms, because labeling carries a stigma as well.
Okay. There is another problem. There are certain personality disorders, or there are certain personalities, and sometimes they may overlap with some of the common, schizophrenia or paranoid, or things like that. How do you differentiate that this is a personality disorder or a mental disorder which needs treatment?
Okay, so even ma'am, within personality disorders, so I have not specifically touched personality disorder as part of common
I
mental
know.
disorders, but personality disorders also are now classified as mental disorders, which are given treatment in terms of both psychotherapy. There are specific psychotherapeutic techniques like dialectical behavior therapy, which is given for personality disorders, and in certain cases, we give medications for personality disorders. And persons with personality disorders are also more prone to develop depression and anxiety. So we treat depression and anxiety as well. But very importantly, to differentiate between personality as part of a normal personality. We all have different personalities. Some people are introvert, some people are extrovert. But being introvert by itself is not a personality disorder. So if again that distress, dysfunction, and the symptoms present for time leading to difficulty in coping with the environment, then we call it a personality disorder. If a person is very introvert, not able to carry out tasks, having dysfunction, so a person may have anxious avoidant personality, which is usually seen in introversion. If a person is very extrovert, outgoing, communicating with everyone, very exhibitionistic type, likes to have very easy emotional volatility, so the person may have emotionally unstable personality. Again, distress, dysfunction, and duration is something which is very important in diagnosing personality disorders as well.
But the major problem actually is that because of the lack of insight or denial of illness, they will never approach.
Yes, ma'am. So very commonly with the behavioral approach, differential reinforcement, limit setting has to be done. You should not give into every demand of person with personality disorder. And the problem comes that, see, personality disorders are now coming up more in the picture because the society is not able to buffer them. Earlier, with the joint family and large family setups, personality disorders were existing earlier also. But you would have family buffer that would support such individuals, and किस तरह काम चल जाता था. With the small families, with now non-compromising attitude that we have in our society, personality disorders are now coming up more into the clinical setup and coming up more. So we as psychiatrists also face the dilemma where to draw the line that it is normal and now it has reached the level that it's now abnormal and needs treatment.
Yeah. Then there is, can you talk a little bit more about suicide? How do you, manage immediate management at a primary care? They need to provide. How do, I
Yes,
think
ma'am.
there are two, three questions on this suicide only. So maybe you can just describe this. This will answer all of them.
Right, ma'am. So suicide is something, like I mentioned, every assessment, mental health assessment is incomplete without assessing suicide risk. And the best way to suicide risk is ask a direct question. कभी आपको ऐसे विचार आते हैं, you can ask with the open-ended questions. कभी आपको स्थिति इतनी ज्यादा गंभीर हो जाती है कि आपको बहुत ज्यादा बुरे विचार आने लगे. किस तरह के बुरे विचार? कभी ऐसे विचार आते हैं कि जीवन जीने लायक नहीं है. कई बार ऐसा लगता हो कि जीवन, इससे अच्छा जीवन ना होता. एंड द नेक्स्ट स्टेप वुड बी, कभी ऐसे विचार आते हैं कि कभी अपना जीवन में खुद खत्म कर लूं या खुद को नुकसान पहुंचाऊं. सो आस्क वेरी क्लियर क्वेश्चंस. डोंट बीट अराउंड द बुश व्हाइल असेसिंग सुसाइड रिस्क. दैट इज द फर्स्ट इंपॉर्टेंट message. Second message, the most important when you find that a person is having suicide risk, two important things to do. Establish a no suicide or a behavioral contract. You have to tell the person clearly, अच्छा मैं समझता हूं कि आपको ऐसे विचार आ रहे हैं, पर मैं आपसे चाहता हूं कि जब भी आपको ये विचार ज्यादा आए, आप अपने मन में ही रखेंगे. आपके पास जो भी आपके परिवार वाले हो उनको इमीडिएटली आपने बताना है कि मुझे ऐसे विचार आ रहे हैं, मुझसे मैनेज नहीं हो रहा है, या उसी वक्त आपको हमारे प्राइमरी हेल्थ सेंटर पे आना है या हॉस्पिटल में जाना नियरेस्ट, और कोई भी ऐसा कदम नहीं उठाना जिससे पछतावा हो. एंड यू एस्टैब्लिश दिस वेरी क्लियरली विद द पर्सन. वी कॉल इट एज अ नो सुसाइड और बिहेवियरल कॉन्ट्रैक्ट. सेकेंड थिंग, होप इंस्टिलेशन. वेरी वेरी इंपॉर्टेंट. टेल देम क्लियरली, हम समझते हैं कि आप ऐसी स्थिति से गुजर रहे हैं जहां आपको लग रहा है कि जीवन जीने लायक नहीं है, पर मैं एज अ डॉक्टर आपको क्लियरली बता रहा हूं, मैं एज ए आशा वर्कर या सीएचओ आपको क्लियरली बता रहा हूं या बता रही हूं दैट दिस इज समथिंग जो कि कॉमन है, काफी लोगों को होता है, इसका इलाज संभव है, आप इससे बाहर निकल पाएंगे, हमें इसका पूरा श्योरिटी है कि आप इससे बाहर निकलोगे, इलाज से आप इस चीज से बाहर आ सकते हैं और एक जीवन जी सकते हैं और आप ठीक हो सकते हो. आपको बस एक उम्मीद की वो किरण ढूंढनी है जिससे आप इससे बाहर निकल सकते हो, और हम आपके साथ हैं आपको इससे बाहर निकालने में. दिस सिंपल सपोर्टिव सेशन एंड होप इंस्टॉलेशन गोज अ लॉन्ग वे इन मैनेजिंग सुसाइड रिस्क. एंड मोस्ट इंपॉर्टेंटली, रेफर. If suicide risk, refer to the medical officer or the psychiatrist.
Anything
After providing
first aid, after this contract and open discussion, they should refer it to a higher level.
Yes, ma'am.
Okay, I think the answer is also very clear. They cannot be treated telemedicine through telemedicine. They need
even in telemedicine, ma'am, when we have such calls, we give them this initial support and we tell them and we connect them with the nearest mental health facility.
Okay. Then can you talk about please explain diagnostic criteria for panic disorder. Does duration of illness matter?
Yes, duration matters in everything. That was my first slide, in fact. Panic attacks are very common. Many people have panic attacks in different situations. When I was during my post graduation, and Dr. Tanmay would agree with me, I guess, that we used to have case conferences as part of PG presentation. Before every case conference, I used to have panic attacks. And Ibhas, ma'am, you already know that being trained at Ibhas, case conference was a huge deal.
Yes, मुझे मालूम है वहाँ
So before every case conference, I would have a panic attack, but that was not panic disorder because it was present only at that particular time. It was, I would come out of it on my own. It was, so there was no distress or dysfunction because of that. I would still carry on with my case conference and would present it well. I would be able to prepare for my case conference. There was no dysfunction. It was only present transiently. It was not present for weeks together. So that's why it was not a disorder. So again, presence of symptoms for a significant duration of time causing distress and dysfunction is very important. For panic disorder per se, panic attacks occurring in the absence of any identifiable situation or event. If we have a situation or an event, it falls into specific phobias or agoraphobia or social anxiety. In panic disorder, person will not be able to tell कि किस वजह से हुआ. एकदम से मेरे को तेज घबराहट हो जाती है, पता नहीं क्यों हो जाती है, मुझे पता नहीं चलता, और उसकी वजह से फिर मैं बिल्कुल ही बेजान हो जाता हूँ, कुछ नहीं कर पाता हूँ, लगता है अब तो मेरी जान गई. This would occur frequently. The number of episodes would be very frequent, 2 to 3 times in a week, 4 times, more than 4 times in a month, and for weeks or months together. Only then we will call it as panic disorder. Diagnostic criteria differ. DSM-5-TR gives certain criteria, ICD-11 gives certain criteria. You can refer to those criteria, but more importantly, understanding when to refer.
I think when they encounter a patient with panic attack, what is the first thing that they should tell? How do they manage? If you can tell them that.
Ma'am, first thing, panic attacks very commonly resemble a myocardial infarction. So if the person, look at the age of the person, if the person is an elderly person, you should rule that out. That is the first important thing. If it's a young adult, no other cardiac risk factors, then unlikely to be a cardiac reason behind it. So rule out the physical causes of it by examination, first thing, if required investigations. Second thing, telling them that this will pass, this is for transient period, and relaxation techniques are very useful in panic attacks. So at the level of primary healthcare, relaxation techniques, pranayam techniques are a component, yoga is a component. So these two are very useful for managing anxiety disorders and panic attacks. If a person is interested, they can get trained in conditions like deep breathing exercises as well as muscular relaxation exercises. These are simple trainings that one can go through, and these are very effective in managing panic attacks. But if it's again very significant, many a times medications are required for panic disorder.
नहीं, आप वो distraction के लिए भी बोलते हो ना, immediately you tell the person to look at 5 different things that distracts the person and aborts the panic attack.
Yes, ma'am, that does help, but sometimes क्या होता है मैम कि ना distraction technique short term में तो they are very very useful, but sometimes people develop that we call that as compensatory or a behavior in these cases. So वो distract बार बार अगर use करते distraction, if the attacks are frequent, that sometimes becomes a maladaptive coping strategy. But in the short term, yes, it distracts. So drinking a glass of water, taking frequent sips of water, engaging in some other activity, that also helps in abolishing or terminating a panic attack.
Very good question in the chat box. I think none of us have the answer for that. And I would urge you two colleagues of mine, this question is it possible to do mental health assessment of all healthcare service providers or all government employees at the time of appointment or on annual basis, or ensure at the time of promotions?
I'll just tell that such kind of discussions are always ongoing. People are discussing this a lot, mental health assessment, or in fact, in many places, as part of recruitment, personality assessment is being done in at least some places that I know of, not in the government sector, mostly in private sector, but mental assessment as part of annual health checkup that has been thought about. In fact, the comments that I gave, which I'll give here, is it's a double-edged sword. Mental health issues as part of assessment and screening done by, we tend to overdiagnose. So a person, they can get a false label of mental health issue, and it carries the stigma with it. Others tend to judge that person. Others, we may say that it will not harm your job. The current Disability Act says that it should not affect your job. You cannot be terminated based on having a mental health issue. But the reality is your colleagues, your seniors, your juniors, they look at you with that lens, and it affects their behavior and their matters. So mental health assessment has to be a confidential assessment. It has to be voluntary in basis. It, at present, at least this is my personal viewpoint, it cannot be imposed or mandated upon any person.
Yeah, it's a very difficult situation. Many of the healthcare providers themselves can suffer from these mental disorders.
Yes.
And at present, currently, there is no such, and lack of insight, lack of, denial of illness, that further, complicates the problem. And there are such certain issues. I'm sure, if we keep the dialogue on, sometimes some fair formula would be there, how to go about managing such situation. And I think can we move to the next question? There is just quick question. Can narcissist trait be corrected?
I'll have to take a full session on this.
Just give them one.
Again, just a simple answer. Personality is difficult to modify. Narcissistic trait or narcissistic personality is a type of personality. It's difficult to change a personality, but one can be taught to adapt their personality traits in a more adaptive manner to the environment that they live in.
I think another part of this is that you cannot change the personality, but if you know how to deal with this such kind of people, that also will help you manage the situation better way.
Right, ma'am.
Okay, thank you, Dr. Bhavuk. अभी questions चलते रहेंगे. I think rest of the questions I will take. Dr. Tanmay is already waiting, and then I also have a presentation on this. May I now invite Dr. Tanmay Joshi to speak on the substance abuse and how do we identify.
Thank you so much, ma'am.
I would also I would like to thank Dr. Bhavuk for his great presentation, and I welcome Dr. Tanmay Joshi, who is an assistant professor in the Department of Psychiatry of AIIMS Bhopal, has over around 11 years of experience in, and his research interests are to develop neuroscience-based assessments and interventions. His keen interest revolves around teaching, research, and motivational interviewing. He also provides training in early detection and intervention of mental health disorders, teleconsulting, screening, and brief interventions for substance use, and has published around 15 scientific publications in various national and international journals. Was recently awarded by Vipra Seva Sangh for his contribution in healthcare. Over to you, sir.
Good evening, everyone. Thank you so much for inviting me. So I'd like to start by thanking Dr. Kotwal sir, Dr. Srivastava sir, ma'am, Dr. Aman, and Bhavuk sir for their august presence over here. Thank you all the participants for having me. I think without further delay, we should get going with my portion of the talk. So I'll just share. I hope it's visible. Am I audible as well?
Yeah.
Yes, yes, you're fine with both the things.
All right. So my topic for today is early intervention in alcoholism, drug addictions, and substance abuse. Many names may have slightly different meanings to each other. We'll talk about it. All right. So following are the learning objectives. If you attend the talk today, this is what you may be able to understand. You understand the whole landscape of early intervention. ये जो early intervention है, ये होता क्या है और क्यों होता है? अर्ली इंटरवेंशन करना है तो अर्ली स्टेज में भी पकड़ना होगा हमें किसी को, फिर कुछ स्ट्रैटेजीज होंगी और फिर कुछ प्रैक्टिकल टिप्स एंड टूल्स होंगे, सबके बारे में बात करते हैं. सो लेट्स जस्ट अंडरस्टैंड ये अर्ली इंटरवेंशन का लैंडस्केप है क्या. 3-4 केसेस हैं, एक बार डिस्कस करेंगे और फिर बाकी पूरा प्रेजेंटेशन इन केसेस के माध्यम से समझने की कोशिश करेंगे. सो द केस नंबर 1 is that of Rahul. He's a 15-year-old student. He recently started smoking cigarettes with friends during school breaks. Teachers are noticing there is some decline. टीचर्स को पता चल रहा है कि कुछ ना कुछ तो दिक्कत हो रही है, एब्सेंट भी हो रहा है. स्कूल के जो काउंसलर हैं वो देख रहे हैं कि पैसे वगैरह उधार थोड़ा थोड़ा मांगता रहता है इधर उधर से, और व्यवहार में थोड़ा थोड़ा बदलाव है, थोड़ा इरिटेबल हो रहा है, थोड़ा रेस्टलेस हो रहा है. सेकेंड केस है आयशा का. ये भी 16 साल की है. थोड़ा सा एक्सपेरिमेंट करिए कैनबिस में, जो भी सोशल गैदरिंग्स होती हैं दोस्तों के साथ, आफ्टर स्कूल पार्टीज, 10th खत्म हुआ है, 11th में गए हैं, थोड़ा बहुत एक्सपेरिमेंटेशन है. पेरेंट्स थोड़ा थोड़ा नोटिस कर रहे हैं कि मूड स्विंग्स तो हो रहे हैं, थोड़ा अकेला अकेला रह रही है, अब रिश्तेदारों से इतना नहीं मिल रही है, बाकी थोड़ा डांस क्लासेस जाती थी, म्यूजिक क्लासेस जाती थी, अब ये सब नहीं कर रही है, पर अपने दोस्तों के साथ फिर भी चली जाती है. एक कम्युनिटी हेल्थ वर्कर है उसी एरिया में जिसने कभी कभी आयशा को देखा है जो डिविएंट पीयर ग्रुप से उनके साथ घूमते हुए. तो उसने जब एक आध दो बार बात करी तो समझ में आया कि इसका कॉन्सेंट्रेशन थोड़ा तो दिक्कत है, और पूछने पे पता चला कि नींद वगैरह में भी थोड़ी दिक्कत आती रहती है बीच बीच में. अर्जुन भी है, 14-year-old है. इसको देखा तो इसको अस्पताल में देखा तो पता चला कि ये कुछ तो सूंघता है, और इसकी जो प्रेजेंटिंग कंप्लेंट्स थी वो डिजीनेस थी, कंफ्यूजन था, नॉजिया था, ये लेके वो आया है. और घर वालों से बात करी तो घर वाले बोल रहे हैं हाँ थोड़ा व्यवहारिक परिवर्तन तो है, थोड़ा सा सीक्रेटिव से रहने लगा है, और नहाता धोता नहीं है, सेम कपड़े पहन लेता है, कपड़ों पे ऐसे सफेद सफेद से निशान भी रहते हैं कुछ कुछ. ये अर्जुन है. और फिर आता है रोहन का केस जो कि 17 साल का है. ये तंबाकू भी लेता है, बीड़ी भी ले लेता है, गांजा भी ले लेता है, शराब भी पी लेता है, और कभी कभी बीच में जाके स्मैक भी ले लेता है, कभी इंजेक्शन भी लगा लेता है. शुरुआत सब कुछ यही है, स्कूल यार दोस्त, कोचिंग के यार दोस्त, इन सब में से किसी से मिल लिया था एक बार शुरू हुआ, उसके बाद धीरे धीरे उनके साथ करते करते अकेला भी करने लगा. इसके घर वालों से बात करी, उन्होंने भी बोला बहुत चिड़चिड़ा सा रहता है, कभी खुश हो जाता है, कभी शांत रहता है, कभी बहुत ही उदास लगता है हमें, कभी एकदम से मारपीट कर देता है, स्कूल में ग्रेड्स गिर रहे हैं, घर वालों से कट कट के रहने लगा है. इसको भी कम्युनिटी आउटरीच वर्कर ने पकड़ा कहीं, क्योंकि वो बाकी लोगों का भी ट्रीटमेंट कर रहा था जो एक्चुअली रेगुलरली कर रहे थे ये सारे नशे जो ये कभी-कभी कर रहा था। बातचीत में पता चला कि हाँ, ये मल्टीपल नशे हैं, कभी भी कोई भी उठा लेता है, पर कोई ना कोई नशा कभी ना कभी चलता ही रहता है। देखने में ऐसा लग रहा है कि हाँ, वेट लॉस किया है क्योंकि इसके कपड़े एकदम बड़े-बड़े से दिख रहे हैं जब ये आया हमारे पास, और हाथ-वाथ पे देखा तो इसकी नसें ऐसी दिख रही हैं जैसे ओवरयूज़ हो चुकी हैं। तो वो जो नीडल मार्क्स आते हैं रिपीटेड इंजेक्शन से, वो दिख भी रहे हैं। तो ये अर्ली इंटरवेंशन है क्या? अर्ली इंटरवेंशन जस्ट मीन्स कि आप सबसे पहले आइडेंटिफाई कर लो, और ऐसे नहीं कि आप अपनी क्लिनिक में बैठे हुए हो, सामने से कोई व्यक्ति आएगा। अर्ली इंटरवेंशन में हमें तो बैठे होना ही होता है, कभी बाजू वाले डिपार्टमेंट से आ सकता है हमारे पास, जैसे कि अभी डिस्कशन हो रहा था कि अगर टूथ एक के लिए आ रहे हैं तो हो सकता है वो भी हमारे ही मरीज हो। एट द सेम टाइम जब आए तो एंगेज भी करना है। सो एक तो आप आउटरीच एक्टिविटीज करें, जैसे कम्युनिटी सोशल वर्कर्स घूमते हैं, अपने अपने एक्टिविटीज करते हैं, ये लोग भी पकड़ लेते हैं, ये लोग भी कुछ इंटरवेंशन करते हैं, उस समय पे आइडेंटिफाई हो जाते हैं लोग। एट द सेम टाइम बाजू से भी रेफरल आ सकता है। तो अर्ली इंटरवेंशन इन लोगों के लिए है कि आप प्रोएक्टिवली आइडेंटिफाई करें, एट द सेम टाइम अगर आ गया तो एंगेज भी करना है ना। किन लोगों को करना है? वो लोग जिनके प्रॉब्लमैटिक सब्सटेंस यूज पैटर्न्स हैं। किसी ने एक आध बार किसी के साथ एक्सपेरिमेंट के लिए केवल एक बार एक कश ले लिया और उसके बाद कहीं मुड़ के नहीं देखा, दैट इज प्रोबेबली नॉट प्रॉब्लमैटिक। एक आध बार शराब पी ली, उसमें भी केवल एक घूंटी लिया, केवल टेस्ट ही किया, मे नॉट बी प्रॉब्लमैटिक। प्रॉब्लमैटिक दूसरी चीजें हैं। दूसरा वो लोग जो कि यूज तो कर रहे हैं, बहुत ज्यादा यूज नहीं कर रहे हैं, पर अगर इनको ऐसे ही छोड़ दिया जाए तो थोड़े दिन में प्रॉपर डिसऑर्डर लेके आ जाएंगे। इन लोगों को कैसे आइडेंटिफाई करते हैं हम आगे की प्रेजेंटेशन में बात करेंगे। बट मोटा मोटा अर्ली इंटरवेंशन मीन्स आप प्रोएक्टिवली आइडेंटिफाई करें। आइडेंटिफाई करने के लिए आपको खुद को पता होना चाहिए कि ये लोग कौन होते हैं। एट द सेम टाइम एंगेज भी करना है इन लोगों को। क्या बेसिकली अर्ली इंटरवेंशन मतलब प्रॉपर सब्सटेंस यूज डिसऑर्डर नहीं बना है, जो कि मेंटल इलनेस होती है वो नहीं बना है। ये जो अर्ली इंटरवेंशन है, ये जरूरी नहीं है कि आप प्रॉपर अस्पताल में टर्शरी केयर में ही बैठे हो या फिर सीएचसी लेवल पे ही बैठे हो तो ही दे पाओगे। आप कहीं पर भी बैठ के अर्ली इंटरवेंशन देने की कोशिश कर सकते हो आप। और कोशिश यही करना है कि जब आप इंटरवेंशन दो तो कलंकित ना महसूस करे सामने वाला। इट शुड नॉट बी स्टिग्मेटाइजिंग, इट शुड बी इन एन एनवायरनमेंट दैट इज फेमिलियर फॉर द पर्सन। आदमी जब अपना घर बार छोड़ के अस्पताल में आता है तो वैसे ही अनफेमिलियर एटमॉस्फेयर हो जाता है। अर्ली इंटरवेंशन यूजुअली कम्युनिटी सेटअप्स में दिए जाते हैं, या फिर पीएचसी, या फिर छोटे क्लिनिक्स, प्राइवेट क्लिनिक्स, ये सब जगह पर दे दिया जाता है। अर्ली इंटरवेंशन को अर्ली क्यों बुलाते हैं? क्योंकि अभी मैं आपको एक कर्व दिखाऊंगा। अगर आपने शुरुआत में किसी के इंटरवीन कर दिया तो आप उसको कर्व बदल सकते हो उसके जीवन का। तो कर्व कैसा दिखता है अभी बात करते हैं। मोटा मोटा अर्ली इंटरवेंशन में होता क्या है? सबसे पहला तो होता है असेसमेंट। असेसमेंट नहीं किया तो आप आगे इंटरवेंशन तो नहीं कर सकते। असेसमेंट करना होता है, एट द सेम टाइम इंडिविजुअल काउंसलिंग भी हो सकती है, क्योंकि एक बार मौका मिलता है किसी भी सब्सटेंस यूजर का अर्ली वाले फेज में, उस समय पर अच्छे से इंटरवेंशन कर लिया तो वो अर्ली इंटरवेंशन बहुत काम का इंटरवेंशन हो जाता है। सो इंडिविजुअल सेटिंग्स में या ग्रुप सेटिंग्स में हो सकता है। लोग ओरल हेल्थ हाइजीन के लिए कम्युनिटी प्रोग्राम्स रन कर रहे हैं, उसमें टोबैको के खिलाफ अर्ली इंटरवेंशन बहुत इफेक्टिव हो जाता है। सो आप मौके ढूंढो, कहीं पर भी मौके ढूंढो, हो सकता है बहुत इफेक्टिव हो जाए। तो असेसमेंट करिए, इंडिविजुअल या ग्रुप लेवल पे असेसमेंट्स हो सकते हैं, आउटरीच प्रोग्राम्स में अर्ली इंटरवेंशन हो सकते हैं, सपोर्टिव मेजर्स, बहुत स्पेसिफिक नीड्स के साथ कोई आ रहा है आपके पास, उस समय भी अर्ली इंटरवेंशन कर सकते हैं। अभी मेरे मन में पता नहीं क्यों डेंटल ही आ रहा है, तो सपोज समवन कम्स यू विद डेंटल केरीज, आप उससे केवल टोबैको की हिस्ट्री पूछ लो और ढंग से असेसमेंट कर लो। जब आप फीडबैक दोगे तो वो भी अर्ली इंटरवेंशन कहलाएगा, है ना? किसी को बहुत नोजिया, वॉमिटिंग और स्टमक प्रॉब्लम्स हो रहे हैं, आपने केवल अल्कोहल की हिस्ट्री पता कर ली, और अगर हिस्ट्री थोड़ी चिंताजनक है, आपने एक फीडबैक दे दिया, कैसे देते हैं मैं आपको बताऊंगा। आपने अगर वो दे दिया तो वो भी अर्ली इंटरवेंशन कहलाएगा। कभी कभी कुछ कुछ दवाइयां भी होती हैं जो दे सकते हैं, पर दवाइयों के रोल के बारे में आज का लेक्चर तो नहीं है। ओवरऑल अर्ली इंटरवेंशन करता क्या है? वो आदमी को सशक्त बनाता है। जो भी नशा कर रहा है, यूजुअली क्या होता है कि उसका कॉन्फिडेंस धीरे धीरे गिरना शुरू हो जाता है, बार बार नशा करते करते। कि धीरे धीरे उसको भी समझ में आ जाता है कि शुरुआत में तो उसको भी लगता था हाँ दोबारा नहीं करूंगा, अभी तो जब चाहूँ तब छोड़ सकता हूँ। तो धीरे धीरे उसमें कन्विक्शन आ जाते हैं कि शायद ये छोड़ने लायक नहीं रहूंगा मैं, हो सकता है यही मेरी मजबूरी बन जाएगी। बट अर्ली इंटरवेंशन ये होता है कि वो एम्पावर द पर्सन, आप उसको सशक्त बनाते हो कि वो इसके बारे में कुछ कर सकता है। तो हमारा गोल क्या है? सशक्त बनाना। कैसे बनाएंगे? हमारा गोल ये है कि वो या तो रिड्यूस कर दे अपना जो भी डोज है, या तो खत्म ही कर दे, अल्कोहल का हो, किसी भी ड्रग का हो। सेकेंड, जो भी वो नशा कर रहा है उसकी वजह से अगर कोई मेंटल या फिजिकल प्रॉब्लम हो रही है बहुत सारे लोगों को साइकोसेक्सुअल इश्यूज हो जाते हैं, मैरिड लोगों को सेक्सुअल प्रॉब्लम्स आ जाती हैं। दैट इज द रीजन फॉर कंसल्टेशन। तो यूरोलॉजी में बहुत समय ट्रीटमेंट कराने के बाद फिर हमारे पास आते हैं, फिर पता चलता है अरे यार ये तो बहुत ज्यादा नशा चल रहा था, बहुत स्मोकिंग चल रही थी, बहुत अल्कोहल चल रहा था, शायद इस वजह से हो रहा है। सो अगर आपने अर्ली ही इंटरवीन कर लिया तो आई थिंक यू कैन मेक अ वेरी बिग इम्पैक्ट। एंड लास्ट, यू हैव टू मेक देम फंक्शनल। वो अल्टीमेटली नशा छोड़े ना छोड़े, सीवियरिटी उसकी बढ़े ना बढ़े, कम से कम काम चलता रहे। स्कूल स्टूडेंट है तो स्कूल जाता रहे, कामकाजी व्यक्ति है तो कामकाज चलता रहे, पारिवारिक जीवन चलता रहे। दीज आर द अल्टीमेट एम्स ऑफ अर्ली इंटरवेंशन। देन नशे की वजह से जो भी उसके जीवन में हो रहा है, whatever detrimental effects are happening due to the substance, you have to minimize them. So you have to reduce the harms that are happening due to substance misuse. For example, opioids ले रहा है, इंजेक्शन से लेना बंद करवा दो कम से कम, मतलब इतना मोटिवेट कर दो कि वो इंजेक्शन छोड़ दे कम से कम, भले ही ओपियोइड दूसरे फॉर्म्स में चल रहा हो। रिस्की बिहेवियर्स दैट लीड टू इंजरी, फॉर एग्जाम्पल ड्रिंकिंग एंड ड्राइविंग। कम से कम व्यक्ति जब भी शराब पिए, भले ही वो बहुत ज्यादा पीता है, पर अगर पी के रोज ही गाड़ी चला रहा है, आपके अर्ली इंटरवेंशन से हो सकता है उसके मन में इतना बदलाव आ जाए कि अब वो गाड़ी ना चलाए, कम से कम एक डेजिग्नेटेड ड्राइवर रख ले कभी भी। उसके बाद वो शायद रोड पे खुद ड्राइविंग सीट पे ना बैठे इन एन इनेब्रिएटेड स्टेट। एंड नेक्स्ट, प्रिवेंटिंग द प्रोग्रेशन। कैसे ये सब प्रोग्रेस करते हैं, एक ग्राफ के माध्यम से देख लेंगे इसको, शायद अगले ही आ रहा है। सो ओवरऑल सशक्त बनाना है, और जो भी नशीला पदार्थ है उसके जो हानिकारक प्रभाव है या जो दुष्प्रभाव है उनको कम करना है। सो बेसिकली कहा जाए तो अर्ली इंटरवेंशन एक लिंक है। लिंक किसके बीच में? पहले तो हर कोई यही चाहता है कि कोई नशा शुरू ही ना करे, एंड सेकेंड, हर कोई ये चाहता है कि अगर शुरू हो गया और बहुत अव्वल दर्जे का हो गया तो उसको बहुत ही इंटेंस इंटरवेंशन मिल जाए। तो शुरू ही ना करें वर्सेस एडिक्शन में एकदम आगे तक प्रोग्रेस कर चुका है, इसके बीच में अर्ली इंटरवेंशन लाई करते हैं। सो इट्स अ लिंक बेसिकली। सो अर्ली इंटरवेंशन काम कैसे करता है, इसके गोल्स क्या है? बेसिकली इसका गोल यह है कि टाइमली इंफॉर्मेशन मिल जाए व्यक्ति को यूज करते करते। हाल फिलहाल में ही शुरू किया है, हाल फिलहाल में जाना है किसी नए नशे के बारे में, तो ये भी जान ले कि इससे संबंधित रिस्क क्या है। सेकेंड, नॉर्मल लेवल्स ऑफ यूज क्या होते हैं इस सब्सटेंस को, कितना ले सकते हैं, कितनी बार ले सकते हैं, कितने घंटे चलता है इसका असर, ये सब भी पता होना चाहिए किसी को। इन्फॉर्मेशन इज की, नॉलेज इज वेरी इंपॉर्टेंट।
Tanmay, can you use mixed language? I know many are Hindi, but some cannot.
हमारे इंग्लिश
Just use
Got
mixed language. I know it's
Got
difficult.
all right. So the next thing is, everyone has to receive information in a very timely manner. When a person has just started to know about a substance, it so happens that you know about tobacco, you know about alcohol, but sometimes some people newly discover cannabis. They want to know cheese kya hai, what is this? So at the same time they should know what are the safe levels of use, how many times can you take it, how long does the result last, how long will you keep lying in intoxication. These are the things. Safe levels of use, what are the safe levels, what are the unsafe levels. So information needs to happen on those lines when you're giving early intervention. And second, you need to also give them strategies how to manage it. When you're drinking alcohol, you can just give an example like, don't take more than one drink in an hour, space out your drinks, things like that. It's a very specific intervention. Give it with that. That also makes a huge difference. So overall, what you're doing is you're empowering the people. सशक्त बनाओ आप उनको। जो लोग serious substance use में है, people who are regular into substance use and they're having dysfunctions in the form of not being able to go to school, work absenteeism हो रहा है, ये छुट्टी ले ले रहे हैं तो दूसरे लोगों को बहुत काम करना पड़ रहा है. So things like that. When one takes leave, the brunt falls on the other people who are actually regular to work. So what you can do is that when a person gets regular, you can decrease the intensity of their substance abuse or misuse at that point of time. So target populations are basically individuals who have a problematic use and mild substance use disorders. Basic age group of the people are during adolescence, those who are just getting into young adulthood, and those people who have very identifiable risk behaviors, those people who are injecting, those who are uh, driving under intoxication, those who are performing risky sexual behaviors, those people who are taking it from dangerous routes and who are taking a very high dose, those people who are mixing more than 2 classes of substances. These are the people who are showing risk factors for, a greater degree of what do we call substance use disorders. So early interventions यही होता है कि escalation रुक जाता है, पूरा use disorder बनने से रुक जाता है, उससे होने वाले harmful consequences कम हो जाते हैं, and it's a very crucial opportunity. You enhance their understanding, you enhance their motivation. This is what early intervention does. It also increases the chances of recovery, because when substance use disorder goes to the severest end, chances of recovery keep getting slim. You also have to decrease the dysfunctions. You have to give them interventions that are apt for the moment. ये नहीं कि शराब बहुत बुरी होती है, हाँ, पता है, उसको भी पता है. But right now, what can he do? This is what you can sort of tell when you're giving an early intervention. And ultimately, everything is about money. You are saving costs for the person, because costs will increase as the substance use disorder gets towards the severe spectrum. They will then go to the hospitals. They will incur huge costs in just assessments, interventions, etc. What happens actually when a person starts consuming substances, that there is a normal development curve. आदमी पैदा हुआ है, 18 का होगा, 45 का होगा, 60 का होगा, 80 का होगा. There's a normal development. But if you take it when you are just in your teens, or even before that, when your brain hasn't developed fully, there are certain key areas about decision making and impulse control. Initial exposure जब आप लेते हो, तो dopamine निकलता है. There is a trigger of dopamine upon your first consumption. What it then does is, when you have euphoria, it creates a memory of that euphoria. This is the memory that people actually chase. So when you take it for the first time, there's a memory for euphoria. Then you take it to twice, thrice, 4 times, 5 times more. There is a reinforcement happening. Now, every time you take the substance on different occasions that are closely gapped, every time dopamine is getting released and fired, and it is leading to euphoria. Now there is an association. बार बार dopamine निकल रहा है, उतनी मात्रा में निकल रहा है. There is a big dose of dopamine that comes out due to substance use. So that's a shortcut to happiness, basically, but very short-lived. So repeated administration of high doses of dopamine give rise to stronger neural connections. Now, this is a little bit of neurobiology that I'm trying to hint towards. You have a brain that is constantly growing. It should not be contaminated, but now you've taken substance. You've taken it once, there is a drug memory, a euphoria memory. You take it twice, thrice, 4 times, the memory and the neural connections for that memory, they start getting a little more robust. And gradually and slowly, you have small difficulty in life, you will try to reach back to that memory. It so happens we all have some favorite objects and items that we like to keep closely. In our moments of distress, we go towards those objects. Drugs overtake everything. You lose your interest in all of those objects, and now drugs are the only thing that happens. And why it happens is this. I've given you a very short description of how it happens. So now, how to recognize the early stages. Now, this is the graph that I'm trying to tell you. What is the addiction spectrum? Towards the left side, you will see that there is a person who has not used it ever, and there is full self-control. At this point of time, if a person starts taking it for the first time, पहली बार कोई भी लेगा, then what is the motivation to do it? The motivation is to have fun and to socialize. So a person starts with the first time consumption. Gradually, it becomes experimental use, because first time consumption, he knows he liked it or she liked it. Now they want to experiment with it a little. कि डोज बढ़ा के देख लेता हूँ, डेली लेके देख लेता हूँ, या 2 दिन बाद देख लेता हूँ, हर वीकेंड देख लेता हूँ. This is experimental. Motivation is still to have fun and to socialize, and self-control is gradually decreasing, but not apparent. It's not evident. Now it becomes recreational. You have free time, you use substance. You have weekend, you use substance. You have a midweek holiday, you use substance. You're meeting with friends. Previously, you would talk without using substance. Now you want substance and talk. धीरे धीरे self-control is taking a dive. अब क्या हो रहा है? After recreational and social use, there comes a point where now you are using it daily, almost daily. And now the motivation is not to have fun. Now the motivation is to get rid of some kind of feeling or some kind of a situation. And your self-control is going down, because now what happens is that even though this same situation you would tackle without using substance, now you want to tackle the situation only with substance. Although you're thinking from deep within, I can do without substance, but you end up doing the substance. Now you see how self-control is going to take a dive. So the right side of the graph tells you where self-control is taking a dive and you're progressing towards the disorder. Left side says कि हाँ ठीक है, control है, ठीक ठाक control है, and the motivation is different. Right side you see the motivations have changed completely. Now you're taking it only because if you don't take it, you may not be able to sleep. If you don't take it, you may not be able to have food. If you don't take it, you might not be able to stand the social scene. दोस्तों से बात करने में थोड़ी हिचकिचाहट हो सकती है. Things like that. So this is a very lay person diagram, but very interesting in understanding. So there are many different terminologies. Let's just talk one by one. Initiation basically is the first exposure to a substance. It is often driven by curiosity, peer influence, stress. And what are your intervention targets when you find someone who has just newly, been exposed to a substance? Because there are a lot of people who come, family members get to know that he has used a substance because they once saw that he came late and he was sleeping a little too much. What do you do at this point of time to educate the person about the risks associated with the substance? You have an open communication with the families that, we understand. Anything happens, bring him back to us. You also should realize he's just started using it. Right now, we need to be sensitive and things like that. Sometimes there will be some mental health conditions and concerns that they will tell you about. Just be open to it and keep assessing the person for it. Then you will have a person who's experimenting. Experimenting means he's not just using it once and forgotten about it. He's going to use it occasionally, every now and then. How? Either there will be a social reason for using it, or there'll be a stress-related thing. Exam aa raha hai, smoke kar leta hu. Things like that. Why? Just to explore the effects. Seniors कर रहे थे, हम भी करके देखते हैं. Overnight जगने का वो है, cigarette तो stimulating है, देख लेते हैं करके. At this point of time, you deliver something called a brief intervention. I'll talk a little in deep about brief interventions. You also focus on harm reduction. For example, if it's a cigarette, you at least tell, don't smoke cigarettes after sun is gone, because it's a stimulating agent. Don't have it after sunset. Else, with time, your sleep may be disturbed. Things like that. Education about safe use, if it's applicable for certain substances. And then exploring how to alternatively cope with any stress. The next kind of use pattern that you will see is regular use. Now, substance use is becoming frequent, integrated into daily routines. कुछ भी कर रहे हैं, substance के साथ कर रहे हैं, खाना खा लिया उसके बाद एक सिगरेट पी रहे हैं, things like that. And it is often done to manage stress or enhance a mood. अच्छा लगने के लिए, mood modify करने के लिए कर रहे हैं. At this point of time, early intervention के target कुछ इस प्रकार होते हैं कि you educate about the risks, you have open communication. Again, so then comes problematic substance use. अब problematic substance use क्या होता है? ये एक proper mental health condition है. Problem मतलब लोगों से लड़ लिया वो problem. There's a road mishap, traffic mishap, that is a problem. Things like that. And it has a separate criteria. So that becomes problematic use. और main चीज यही है कि वो जो loss of control आपने देखा है उस graph में, as soon as you realize that the control is getting lost, like a person is resolved, I'll cut down. Person is resolved, I'll not do it now. I'll not hang out with those friends who consume it daily. But then ends up doing it. This is what is loss of control. He thinks I'll only have one glass of whiskey or just one pint of beer. Doesn't end up doing it. Ends up finishing everything. Each and every time that he's thought about it. These are hallmarks of loss of control. So, and then इसमें आपको यही करना है कि वो प्रॉपर डिसऑर्डर में ना चला जाए कि उसको डिसफंक्शन हो रहा है, like he doesn't miss out on work, doesn't spend huge amounts of money in getting the substance and in dealing with all the mishaps that happen with him. So this becomes your target. And when there is substance use disorder, then there are very focused interventions that you need to do. So now what we're going to talk about are what are the environmental factors that increase your vulnerability to have substance use disorder. So environmental risk factors say that if there is a person who lands up in your clinic or in front of you due to any reason that you understand is because of a substance, then you may assess him or her, is there any unstable or dysfunctional family environment right now? Is there any family member who is using the same substance? Does he have a peer group who has recently started using the same substance? Has there been any very adverse event that has happened with him, either physically, emotionally, or sexually? Now, this requires a certain level of expertise and this requires a certain level of sensitivity. So tread very carefully over here, but do have it in your mind. Has parental supervision just taken a hit? Have parents just recently gone somewhere? I'll give you an example. I used to work in an area close to Ames Rishikesh, where people were sort of displaced from their place because Tiri Dam was being built. So there's a whole area, it's called Visthapiz. And you see there's a big prevalence of substance use. Why? Because parents have still not given up their house in the hills, but for better educational opportunities, they've sent their children down. So they're living with their grandparents. Parents are sending money, but there is no parental supervision. So that becomes a window for deviant peer groups to influence, where these people have just gotten money from the government scheme, and then peer groups can easily influence them. And there are some psychological stressors and family stressors that are going on, and this becomes a window for them. So lack of parental supervision during this point of time also is, one factor. And then some people may have previous risk factors like a temperament that is very irritable and very aggressive behavior since childhood only. So they are also at risk. Bade risk factors, they're like stress, exposure to violence, recent violence, discrimination in the society, and a person who just cannot make positive social connections. These people are at risk. Now, when a person starts using substance, how to identify them? You can identify by looking at their behavior. For example, changes in the individual's demeanor. Rehen sehen pura badal jata hai. Okay? Second, a person has started to be more secretive and started withdrawing from the family members and family activities. He's become uncommunicative. He's exhibiting drug-seeking behavior, like, despite having some very adverse events. He's just had a road traffic mishap under intoxication of alcohol, but still, when friends come over the next weekend or holidays of Diwali, he'll just, fight with family members. I want money, and then he'll take the money and go and again use substance. There are some shifts in personality. A person knows that, the whole neighborhood knows this person has been very reserved, very shy, very quiet, and suddenly he's getting very irritable. So shifts in personality. Sometimes they get very deceptive. Sometimes they be very disrespectful towards others. They become very irrational. They start making some very insane demands and very dramatic. They'll just weep at the drop of a hat. So these behaviors should point an inquiry into whether a person is using substance or not. And then neglecting responsibilities at work, school, home, ये सब तो होता ही है. So next, physically. Physically, if you see someone is losing weight in an unexplained manner, not eating very well in your family context, someone has very bloodshot eyes, dilated pupils, noticeable decline in personal hygiene, giving very foul odors as if he's not bathed in a long time, neglect of appearance, very unkempt, slurred speech, difficulties in coordination, talking to you but drooping eyelids, etc. Unusual smells sometimes. Inhalant लेने वालों से आ जाता है, alcohol पीने वालों से आ जाता है, cannabis लेने वालों से आ जाता है. So these are things. Now, what do you do? What are your strategies? Strategies are like, first of all, you need to assess motivation wise ये है क्या? I'll just show you what are the stages of motivation. कि आदमी सोच क्या रहा है जब वो नशा ले रहा है, what is going on in their mind? Do they even consider this to be something that they're not supposed to be doing? Assess that. And if you have to make an intervention, the first thing you need to know is the person even ready to change? Is it coming from within? Has the person even thought of changing? So these are two things that you need to focus on. If you're giving any intervention that can be classified as an early intervention, even late interventions, this thing is something that you need to do as a part of your assessment. Get to know what stage of motivation are they in and what is the readiness of change. बातचीत करोगे आप तो मैं कुछ statements अभी बताऊंगा अगली slide पे. You look at the statements and you will be able to mota place the person. Where is the person lying right now? So these are the stages of change. Pre-contemplation मतलब व्यक्ति ने सोचा भी नहीं है. He's not even thought about doing something about the substance. He says there is no problem. Contemplation, people think, okay, problem may be there, may not be there, but they're at least thinking about it. Yeah, there exists a possibility, there may be a problem. Then comes preparation, of persons preparing. Then comes action, the person actually starts doing something for it. And then there is maintenance. And if a person is not in maintenance, then they will relapse back and use the substance again. It's basically a circle, but I've given it in a step ladder manner because the next slide, pre-contemplation. Pre-contemplation means pre of contemplation. Contemplation means to think pro and for and against. Pre means not even reach to that stage. What happens in this stage is that there is a problem behavior. No one can deny that there is no problem behavior. Problem behavior is there. but the person is not thinking about changing even in the next 6 months. Person says, as far as I am concerned, I have no problems. ऐसा हो सकता है that me and my friends are creating a ruckus. ऐसा हो सकता है my parents are troubled because of me, but I don't think that it's because of me. I think they have their own issues. That's why they're doing this. Sometimes people directly say, "ये क्या psychiatrist, psychology, this is all boring." No, मैं थोड़ी देर नशा करता हूँ, मैं अपनी प्रॉब्लम के बारे में भूल जाता हूँ. Why can't people just forget about their problems? Okay. Next, okay, मेरे में दिक्कत है ना, मैं कर रहा हूँ ना, ठीक है, मैं कर लूंगा चेंज, मैं देखता हूँ, ठीक है. So sometimes people just neglect. You try to tell them, you'll have this problem, and they'll say, no, I'll see about it. I'll see later what to do. So that's the pre-contemplation stage. Then comes contemplation. There is a problem behavior, and a person is considering some change in the next 6 months. So a person may think that, okay, I've had 2-3 parties where I've had a little too much of alcohol. करता हूँ कुछ, I'll do something in the next few months. So you will hear statements like, it might actually be worthwhile to work on my problem. मैं खुद पे काम करूँगा तो हो सकता है कुछ फायदा हो जाए, अच्छा ही हो. I've been thinking and I might want to change something about myself. So a person is now actively thinking and he says, okay, there's a possibility I may change something about myself. Then a person says, no, I know I have a problem. And I think I should work on it. Over here, please note that the person is talking in context to himself. He's saying, I have a problem, I need to change and work something. And then sometimes people say, ठीक है, मेरे को पता तो है problem क्या है. I wish मेरे को ये भी पता होता कि इससे बाहर कैसे जाऊं. I wish I had more ideas. This is what is contemplation. Then comes preparation. Preparation एक बीच का स्टेज होता है. कोई भी एक्शन लेने से पहले कभी-कभी क्या होते हैं, ये लोग कुछ देर के लिए ट्राई कर लेते हैं बीच में. Any regular user may give up for a while. For example, Navratri आई. People then take a break. Okay, yeah, maybe there's a Tuesday in 1 week. So one day of the week they'll say, nahi, is din nahi karenge. So there is a problem behavior and they're considering change in the next month. And in the last 24 hours before coming here or whenever in the last 1 week or so, they've made an attempt. 1 week bolo, 1 year bolo, they've made an attempt to do some change. If they're drinking 1 bottle a day, at least they've come down to drinking 2 quarters, 1 quarter, something like that. Then comes action stage. There is a problem behavior and they have made some change in the last 6 months. So then they make statements like, at times my problem is difficult, but now I've started working on it. I know there's a problem. I had accident. I lost so much money. I made some risky investments, lost it. I'm having fights with my wife, but now I'm working on it. Sometimes they say that, okay, I've started working on it. Not every time that I'm successful, but okay, at least I'm trying. कर तो रहा हूँ, कम से कम कर तो रहा हूँ. बाकी सब तो कुछ करते भी नहीं है. मेरे दोस्तों को देखो, सबके साथ ये हुआ है, करते भी नहीं है. मैं कम से कम कर तो रहा हूँ. Next, they say, sometimes they say, okay, I've started working on it, but if you give me some more help, I'm open to it. So it's like people like that. Then comes maintenance, that they've made changes. Now the problem behavior is absent. They've already made the change, and in the last 6 months, they've made this change. And the problem behavior no longer exists. Then people, when they're in the maintenance phase, they start saying things like, I've been successful in working on my problem, but I'm not sure I can keep up the effort on my own. So you help me in staying in the maintenance phase. यहाँ पे दवाइयों का बहुत काम आ जाता है कई बार. आपने अल्कोहल यूज डिसऑर्डर की दवाइयाँ देखी होंगी, डाइसल्फिरान, नैल्ट्रिक्सोन, etc., etc. This is the phase in which it works. Okay? Sometimes they say, I'm not following through with what I had already changed. उतना अच्छा नहीं कर रहा जितना अच्छा मैंने सोचा था. छोड़ तो दिया है, तो अब आगे दोबारा चालू ना हो जाए, आप मेरी मदद करो. So I've done it, but I don't think I'm so confident in staying the way I've managed to become. So help me if you can. Okay? So there are many statements like this that people give. So overall होता यह है कि किसी को अगर प्री कॉन्टेम्पलेशन से कॉन्टेम्पलेशन के स्टेज में जाना है तो उसका नॉलेज चेंज करना पड़ता है. उसका नॉलेज मतलब what does he know about the substance and what can the substance actually do. When a person is in contemplation to preparation, don't give a lot of energy on telling him about the substance. He knows about the substance. That is why he's thinking about a change now. So अब attitude towards the substance change करने पे ज़्यादा focus करना है. So here we need to bring about the attitude change. Then when a person is in preparation to action, attitude भी है उसका change होने के लिए, knowledge भी है कि change करना बहुत ज़रूरी है. How do you help the person bring about a behavioral change? So that's what pushes the person from pre-contemplation, from preparation to action. And likewise, from action to maintenance and staying in maintenance and preventing a relapse. These are things that need to be done. So identification is very important. Get to know which stage is the person in. Because if a person is in preparation and you keep giving leaflets, alcohol ke bare mein dekho ye padho, ganja ke bare mein dekho ye padho, you're missing out. Person will not come back to you. You've lost that window of giving an intervention. So it's always nice. Assess the person properly and then give an intervention. So there is this one concept I'll be talking and trying to give you a practical demonstration of, and it's called SBIRT. S is for screening. Screening kaise karna hai? I'll give you some tools. They're freely available, very short tools you can use. Then comes brief intervention, and then comes referral to treatment. Referral to treatment, Bhavuk sir has already talked about. There is a big system that exists in psychiatry. MNS package, Ayushman Bharat, government schemes, and the whole structure of healthcare system. You know that. Referral to treatment. स्क्रीनिंग कैसे करना है, ब्रीफ इंटरवेंशन कैसे करना है. स्क्रीनिंग के लिए तो क्वेश्चनेयर अप्लाई करना होता है. क्वेश्चनेयर मैं आपको भी बता दूंगा. लेट्स टॉक अबाउट ब्रीफ इंटरवेंशन. जब क्वेश्चनेयर लगा दिया तो क्वेश्चनेयर से ही लिंक्ड ब्रीफ इंटरवेंशन में क्या बोलना है इसके ऊपर बात कर लेते हैं. व्हाट इज द फर्स्ट स्टेप? सो सपोज यू मेट अ क्लाइंट, he was brought by someone or the client came on his own. When you meet the client and you've delivered the screener, I'll tell you the screeners later. Let me tell you what to do after delivering the screen first. So when you deliver the screen, ask the client. The step one is asking clients if they're interested in seeing their questionnaire scores. Pehle interest jagao. Are you interested in seeing how you scored on the questionnaire you just completed? Then comes the second question. Now when the person says yes, yes, tell me, how did I do? Then comes step two. Step two में दो phases होते हैं. ये सब आपको मैं बता दूंगा, रिसोर्स गाइड बता दूंगा, उससे आप पढ़ सकते हो. इट्स वेरी इजी. Step two is the actual feedback. You ask the person questions as a screener. Now you will give feedback. Feedback is in two steps, two parts. पहला part है score बता दो and the level of risk associated with each substance. Now this brief intervention that I am telling you about is about an instrument called ASSIST, ASSIST. WHO ने ये tool बनाया था. So WHO has made this and it is freely available on the WHO website. You can download this. It's for use in primary care setups. Once you have given that ASSIST tool, once you've administered it, then this is the conversation you need to have. The first question is, do you want to know how you scored? Second is, these are all the substances I asked you about, and these are your scores for each of the substances. Now you point out, usko dikha dena, aap score card bhi hota hai usme. At the end there is a score card. As you can see, your score on tobacco is 16. So हर score के साथ एक risk लिखा हुआ रहता है उसमें. You can give that feedback. There's your score, there is your risk. There's your score for alcohol, this is your risk. For marijuana, there's your score, there's your risk. All the other substances were in low risk. Moderate risk का क्या मतलब है? Moderate risk means you are at risk of health and other problems from your current pattern of substance use. अभी आप जैसे ले रहे हो, you may have some problems. अभी भी and in the future also. Second part is communicate what risk. So because you're in the moderate risk range for marijuana use, the kinds of things associated with your pattern are problems with attention, problems with motivation, feeling anxious, panicky, depressed, difficulty in solving problems, remembering things, high blood pressure, asthma, bronchitis. बहुत सीरियस हो जाएगा तो साइकोसिस भी हो सकता है, हार्ट अटैक्स के चांसेस भी बढ़ सकते हैं, एयरवे डिजीज भी हो सकता है, कैंसर तक हो सकता है. This is the second part. Step 3. You don't only give feedback and you don't only tell them what risks they have, you also tell them an advice. The best way you can reduce your risk with these things or these harms that are happening to you is either you cut down or you stop using the drug. There is a plain simple advice. You either cut down or you stop. ये नहीं बोलना कि you really need to do something about your drug use. या मुझे बहुत चिंता हो रही है आपकी, या आपको तो कुछ करना चाहिए. This is not what you need to say. You have to give a very plain, simple, to the point advice. You need to cut down or stop. Only two acceptable things. आज की डेट में इस समय जो आपका यूज है, you either cut down or you stop. Step 4, allowing the client to take the ultimate responsibility of their choices. It is not your responsibility that they stop. It is their responsibility that they do something about it. Your responsibility is to show the mirror. This is what brief intervention is. You don't give lectures and sermons. You give very pinpoint advice. What do you do with this information is up to you. I'm just letting you know what kind of harms are associated with your pattern of use. Okay. Then you ask the client, how concerned are you by the score, by the way? Then you start something that is called part of motivational interviewing. What are the good things about the substance that you're using? And what are some of the less good things that you do about your substance? So you ask both. You ask the positives about the substance that they're using as well as negative. And then you summarize the whole thing. So you summarize in a way such that, so from your assessment, you like drinking because it relaxes you. And the first couple of drinks make you really happy. So you're very talkative, you're very confident when you start drinking. But you don't like that, you find it difficult to stop drinking once you've taken 2-3 drinks. And then you start getting into arguments when you're drinking that often, and it results in you doing so many things that you regret the next day and ending up in hospital. So you've made a whole narrative of his problem. So you like drinking because this just happens. Gradually what happens is that you start losing control, then this happens, then you regret. So you're giving a good feedback to him. It's called reflective feedback. And then you ask the person about the less good things. Do the less good things concern you? आपको दिक्कत होती है वो जो अच्छी चीजें नहीं होती है उसके बाद कैसे दिक्कत कैसे होती है? So it's like that. So आप 3-4 items उसको ऐसे feedback में दो, and this is what brief intervention is. You want to understand step 5. How concerned you about your score for the drug? For example, what happens is when you give this feedback and you give the score, every instrument gives you a different level of score. So you need to ask the client, आपको ये score पता चला तो आपको इससे कितनी दिक्कत हो रही है, मतलब आप कितने चिंतित हो इसके बारे में. That's what you want to know. Is it even stirring the person up or not? ठीक है. So at the end of the time, at the end of the brief intervention, what happens is you give a report card to the patient, and you give general information pamphlets about the substance that he's using, and then there is a guide. There's a self-help guide. So this resource, WHO Assist, it has everything. So this is my one take-home message for all of you. WHO का assist जो है वो आप download कर लें and read how to deliver it. That is going to be very helpful for you. So there are other versions also, like motivational interviewing. There are some no wrong door approaches, outreach and education campaigns, family intervention. ये सब early intervention के part होते हैं. Practically कैसे करें? So there are some practical tools. I'm giving you 4 tools. ठीक है? The first tool is assist. Assist का full form ये है. Alcohol, smoking and substance involvement screening test. Target age group adults हैं यहाँ पे. It's not for adolescents and children. You administer. You ask the question and then you write down everything. So it's an 8-item questionnaire. WHO से है. Craft has a very interesting explanation. So you ask about you ask an adolescent, have you ever been in a car where others are using substances? So craft is a very interesting questionnaire for adolescents to elicit if they're using substances or not. तो आप उनको भी दे सकते हो, वो भर के आपको दे सकते हो. तो 6 आइटम्स हैं इसमें, यूथ के लिए है. So craft is another thing that you should have in your practice if you intend to ask about substance use and involvement. Then if you want to specifically ask about alcohol, there is Audit C. Audit C has only 3 questions. It's very brief and very effective in catching people who have an alcohol use disorder. I'll show you a snapshot of Audit C. वरना original audit तो 10 सवाल का है. But Audit C is what I would urge you to know at least. 3 सवाल पता होने चाहिए शराब पीने वालों से पूछने के लिए. And DAST 10 is for all the other drugs. Alcohol छोड़ के बाकी सब drugs की से पूछना है तो 10 आइटम का एक क्वेश्चनर है DAST 10. Drug abuse screening test. This is what Audit C is. There are only 3 questions. How often did you have a drink containing alcohol in the past year? So how often is this? On the days in the past year when you drank alcohol, how many drinks did you typically drink? So first you want to know the frequency, then you want to know the quantity, and then you want to know heavy drinking kitni baar hui hai. So how often did you have 6 or more if you are a man, and 4 or more if you're a woman or more than 65 years of age on one occasion. So these are very sensitive questions. If you ask an alcohol going person about these three things and they score anything that is alarming, you need to refer the person. Now, there are some standards internationally that people have given. वो क्या कहते हैं कि सोशल ड्रिंकिंग जो आप बोलते हो, नहीं मैं तो सोशली ड्रिंक करता हूँ, उनने सोशल ड्रिंकिंग या किसी भी टाइप की ड्रिंकिंग के लिए सबसे पहले एक स्टेटमेंट दे दिया है कि पीना तो बिल्कुल नहीं है, अवॉइड करते बने तो बेस्ट है. इफ यू अवॉइड ड्रिंकिंग दैट इज द बेस्ट. If you have a drink and you want to call it social, limit it to 1 drink or less if you're a woman, 2 drinks or less if you're a man. Binge drinking. Binge drinking means 2 घंटे के अंदर, if you're a man and if you had 5 drinks or more, and every drink is like 30 ml of whiskey, या फिर 1 pint of beer. If you've had more such, if you've had 5 pints or 5 drinks, मतलब 5 bottles or 5 drinks of whiskey, 5 bottles beer, 5 drinks of whiskey, you are into binge drinking. And for women it is 4. Then heavy drinking, again 5 or more drinks on a day or 15 drinks or more in a week for woman or for man, and 4 or more in a day and 8 or more in a week for a woman. 5 drinks per day does not mean that आप 7 दिन 5 drinks से कम ले लो तो चल जाएगा. 15 आपका पूरा वीक का कैपेसिटी है. So things like that. So ultimately, I'll conclude by just saying that early intervention is a very vital strategy for addressing the significant health concern that is substance use. Early intervention by proactive identification and timely support, medical professionals can play a very crucial role. You can prevent the progression to more severe conditions by improving the long-term health outcomes. Integration of techniques like SBIRT, what I showed you, screening, brief intervention, and referral to treatment are essential competencies. If you're a medical professional and you're posted in front of a patient, you should be knowing this. So medical community per se can significantly impact the trajectory of substance users in a very, very effective manner. And this can lead to healthier individuals, healthier communities. So these are some references that I've used. And thank you. We can take some questions.
Thank you, Tanmay, for briefing us about the early intervention, how to identify the problematic drug use in adults and adolescents. I hope the participants today found it useful, and they'll be able to use some of these tools to screen early. Identification is very, very important. Then there are all options available that you can motivate the person to give up this habit. But once they become habitual, only I think harm reduction strategies are left with you. And that's quite a sad position. I'm sure there must be a lot of questions. I will ask you to stay because I have a short presentation on profile of these drugs to be used in common mental disorders. We kept this session because I look after the essential medicines list, and I was involved in developing this list for various states. And when it came to the psychiatry medicines, most of the doctors, they were very reluctant to include it. Although these are very common, the first point of contact is the general physician only. But somehow because some अंदर से कुछ डर है, कैसे यूज करेंगे, क्या side effect होगा, there was a lot of reluctance. So, and there is a district mental health program which is ongoing, but if you look at the consumption of these medicines, it is not that up to the level otherwise we anticipate from the magnitude of the problem. So I will briefly go through the profile of these medications. I will just focus on the what is the criteria that you use for selection of it, what are the ADRs or precautions that you need to take. There are antidepressants. Babu already explained about the different categories of drugs which can be used: antidepressants, antipsychotics, benzodiazepine, anxiolytic drugs, drugs, and then drugs used for bipolar disorder, affective disorder. So mainly this group of SSRIs, fluoxetine, sertraline, and escitalopram. These are the drugs which are used mainly as a first line of antidepressants, general depression, generalized anxiety disorders, OCD, and even post-traumatic stress disorder. Commonly, you see that nausea, insomnia, headache, sexual dysfunction, increase anxiety early in the treatment you may see, and the weight changes over the period may be seen. Now, one particular thing that you should keep in mind is that the antidepressant, as a general in class, they take about 2 to 4 weeks to show clinical effect. So many people, it is not like any other class of medicines where paracetamol will have start action in few hours, or one antibiotic like in 1 or 2 days. Here it may take 2 to 4 weeks to show clinical effects. Therefore, for immediate follow-up within 2 weeks is important for tolerance, because many times the patient may experience these ADRs and may discontinue because of these ADR. So follow-up in 2 weeks for tolerance and 4 weeks for response should be. So on full onset peak effect may take 4 to 6 weeks to show full response to a drug. So, and also, as Bhavuk was saying, monitor for suicidal ideation, especially, again, this is very important in initial weeks of treatment and in young adults. So avoid abrupt discontinuation of these medicines, because there could be a risk of withdrawal symptoms, and use these drugs cautiously in patients with renal and hepatic impairment. There are certain interactions, but I think that at a primary care level, that should not be a problem. And the duration of treatment is prolonged. It is again that it is not that a person has taken for 1 or 2 months that the treatment would be complete. It needs to be continued for at least 6 to 9 months, and after symptom remission. So it is not a total duration that you have to, after symptom remission. And we need to educate our patients on delayed onset of action and importance of adherence to medication. So the dictum here is that you start low and go slow. Don't start with the full dose, you start with the low dose and increase the dose slowly. Then there are SNRIs like venlafaxine, duloxetine. Here they are useful in depression with somatic symptoms or generalized anxiety disorder, or where there is associated neuropathic pain. Common ADR with venlafaxine is BP increase, particularly, and GI upset, sweating. So that is why venlafaxine is not recommended, not a first line choice for patients with hypertension. Again, duration is the same. Vortioxetine has fewer cognitive and sexual side effects. Benzodiazepines are another group of drugs that we use very commonly for management of acute problems, withdrawal symptoms, anxiety, panic attack, insomnia, and it is used for status epilepticus, alcohol withdrawal, etc. Again, drowsiness, dizziness, cognitive impairment, dependence and withdrawal symptoms. If you use it for a long time, it is the serious concern. So therefore, benzodiazepines are recommended only for short term only, 2 to 4 weeks only. Avoid in elderly due to fall risk and cognitive decline. So benzodiazepine should be sparingly used. If you have to use benzodiazepine for elderly, use a short acting one. Don't use the long acting benzodiazepine, because and long term duration beyond 3 weeks, if you use benzodiazepine, there is a risk of tolerance tolerance here means that to achieve the same response, the dose has to be increased. So, and dependence would be there. So, and also if you combine benzodiazepine with alcohol or other depressant, there would be additive effect here. And benzodiazepine, if the patient has been taking for a long time, it should be slowly stopped, particularly after prolonged use. Don't abruptly start, because then withdrawal symptoms will be there. So consider short half-life options for elderly. So these are the drugs indications and the choice of benzodiazepines. When it is anxiety, what do you use? Insomnia, alcohol withdrawal, hepatic, procedural, these are the indication. And choice of benzodiazepine differs because of, these are decided because of the duration of action. These benzodiazepines are classified as short acting when the action is between 3 to 8 hours, intermediate acting 10 to 20 hours, long acting if the action is for more than 24 hours. So diazepam, chlordiazepam, clonazepam, they are preferred in alcohol withdrawal and epilepsy. Short acting one are midazolam, triazolam, and that is why they are used for procedural sedation. Then intermediate like alprazolam, lorazepam, temazepam, they are useful for anxiety and sleep disorder. So depending on the metabolic pathway, again that you have to select the antibiotic. So patient characteristics when you are choosing these benzodiazepine, elderly prefer short acting, or you can use this synonym LOT drugs. L stands for lorazepam, oxazepam, and temazepam, because then this will reduce the risk of sedation and falls in elderly. So again, pregnancy, generally you should avoid diazepam and diazepoxide have higher fetal risk, and lorazepam is preferred when necessary. Similarly, respiratory diseases prefer shorter one. History of substance misuse, use these benzodiazepines cautiously or avoid altogether due to abuse potential. Then higher potential, you will see a higher abuse potential is also seen with short acting, rapid onset like alprazolam, diazepam, benzodiazepine, and whereas intermediate and slower onset benzodiazepines like oxazepam, clonazepam have lower abuse potential, and the potential side effect, sedation, cognitive impairment. So if these are the problem, avoid long-acting benzodiazepines, especially in elderly. Falls and fractures, then prefer short or intermediate acting benzodiazepine with careful dosing in these patients. Now, here is a patient, sometimes you may use to use the combination of the various drugs. For example, in generalized anxiety disorder with sleep disturbance, then you may have to use these benzodiazepine. So, but then these are the core of the treatment for generalized and anxiety disorders, but use of benzodiazepine should be limited here. You may, if the insomnia is a problem, then you may use non-benzodiazepine medicines for insomnia. Again, these are divided based on the onset and duration of action. Rapid onset, like Gelipolon, they are useful for difficulty in initiating sleep patients. Some patients find it difficult to go to sleep and they have minimal next day sedation. Intermediate, like zolpidem, immediate release, rameltation, this can be used. Longer duration is esgopiclone, zolpidem. Extended release can be used for insomnia, and suvorexant is suitable for sustaining sleep. Again, there is criteria which one will be used. Generally, you can remember, if there is a difficulty in initiating sleep, you use the immediate release preparation, short acting one. And if there is a difficulty in maintaining sleep maintenance, that longer acting controlled release preparations can be used. And of course, then avoid as far as possible these drugs in elderly patients. Then again, there are criteria, substance. If there is a history, there is a possibility of abuse potential is there. Avoid benzodiazepines and even non-benzodiazepine group of drugs for sleep. And then if there are comorbid psychiatric disorder, try and use a drug which has both antidepressant as well as which can treat the insomnia. For example, mirtazapine or trazodone could be a good choice if there is a coexistence of depression or anxiety, if they are together there. So, if the sedation is the problem with a drug, then you can try the, sometimes the patient may come and say, this drug is very sedating, I'm not able to do my daily routine, or I cannot go to the work, or I feel sleepy during the daytime. Then perhaps you can switch the timing of these drugs. So use the drugs which have a lower risk of dependency. Even non-benzodiazepine drugs have abuse potential, so don't just take it that zolpidem type drugs can be used. There is no risk at all with these drugs. So then again, tricyclic antidepressant is another group, like amitriptyline, nortriptyline, imipramine. These are almost the first generation antidepressant drugs. Now along days, these are hardly used, but these are useful when there is a associated pain in patient. Neuropathic pain is there, depression plus neuropathic pain is there, or they are also used in migraine prophylaxis and nocturnal enuresis in children. Mainly these have been not used because of their side effect. They have strong anticholinergic effects, sedation, dry mouth, constipation, urinary retention. Again, this urinary retention could be a problem in elderly patients, blurred vision, orthostatic hypotension, cardiac arrhythmias. So because of these side effects, these should be avoided in elderly. Use cautiously these agents in patients with cardiovascular disease, and they can be lethal in overdose, can lead to arrhythmia and seizures. So monitor, go slow again here with the dose, and monitor these patients with ECG in high-risk patients. Then again, I think I can, because there is time is short now. If there is a elderly man with neuropathic pain and low mood, perhaps you can use nortriptyline at bedtime, because this will have a fewer and titrate the dose as per the need for pain and the mood. Then there is another group of drugs called atypical antipsychotics. Just a minute. Yes, just a minute. But give me just 10 minutes. Okay, good, thank you. Then there are atypical antipsychotics like risperidone, olanzapine, quetiapine, aripiprazole. Again, these are used for schizophrenia, bipolar disorder, acute manic phase, and for maintenance, augmentation in depression. But the major common side effects with our weight gain, sedation, hyperglycemia, particularly with olanzapine type of antipsychotic, lipid abnormalities, and extrapyramidal symptoms. These are more common with the first generation typical antipsychotics like haloperidol, less with the atypical one, but they do also have extrapyramidal symptoms, and QT prolongation should be there. So these patients should be monitored regularly at baseline. Before you start, you do the weight, you measure the fasting glucose and lipids, and then follow this regularly. Again, use these drugs cautiously in elderly with dementia. In elderly with dementia, you use quetiapine. This is better tolerated, has lesser extrapyramidal symptoms, and is safer to use this in elderly patients. So just Okay. There is if you use risperidone, there could be increased risk of stroke or death in these patients. So metabolic syndrome is a problem, is a side effect with atypical antipsychotics you have to manage. But if generally olanzapine is and aripiprazole are considered safer options, and if the mother is getting these antipsychotics, then you have to monitor the neonate for this. Again, treatment for schizophrenia is long-term, often lifelong. In schizophrenia, there may be remissions and relapses. It depends on the patient. So it should be tapered gradually if you have to stop this. Then mood stabilizers are lithium, sodium valproate, carbamazepine. Lithium, I think, is mostly used by the psychiatrist specialist only, but it's a very good drug, very old drug, but very good drug generally, but it is a high risk medicine. Difference between the safe dose and the toxic dose is small, so it needs a regular monitoring, but otherwise it's a very good drug. You need to monitor lithium levels, thyroid function and renal function, and avoid dehydration, and drugs like painkillers and ACE inhibitors that can increase or decrease the lithium level. Valproate is a very commonly used drug for bipolar disorder, in epilepsy. Very well tolerated otherwise, but weight gain, GI upset, liver dysfunction and teratogenicity are very important. So if the woman is planning to become for pregnancy, valproate should be avoided because it has a high teratogenic risk. Again, it also needs monitoring of LFT because of the liver dysfunction that it can cause. So it should be used with caution in women. It can you need to discuss the contraception with the woman. Carbamazepine is again used for the same. Additional indication is trigeminal neuralgia, epilepsy. Here you need to monitor complete blood count, LFT, and there is a risk of this emergency, dermatological emergency, Stevens-Johnson syndrome, and this is particularly seen in this genetic if this gene is found. Take these. If there are any drug rashes with carbamazepine, this should be immediately noticed. So again, I think bipolar disorder, here you need to sometimes take the combinations. Valproate and olanzapine is usually, olanzapine will help you for the rapid control if there is severe agitation. So I think other mood stabilizers must be continued long term. So these are some of the common ADRs with antidepressants and their management. So you need to titrate this, look for this, follow up in first 2 weeks to look for this, and consider switching from one. Sometimes you may try with one antidepressant, patient may respond. If the patient is not responding, then you may have to switch to another group. Sometimes this does works in 1 or 2 drug trials, but sometimes you may need more. So, but these are some of the situations. If these can be easily managed, by changing the timing, taking the food. Some of them are self-limiting. If there is a sexual dysfunction, dose reduction if possible, or you may switch to bupropion or mirtazapine. Or insomnia. This is some people come and say ki, I'm not able to sleep after taking these medicines. So you can shift the dose to morning. Short term, you can try melatonin or trazodone. Like this, you can do some of these. So hypertension patient, don't give venlafaxine, it increases the catecholamine levels. So similarly, you have to look at, what are the comorbid symptoms. So which antidepressant would be more suitable for which comorbid, if it is depression plus fatigue, consider activating agent fluoxetine. If it is depression plus insomnia, consider sedating agent like mirtazapine. If there is a suicidal risk, avoid tricyclic antidepressants because they can be lethal in overdose. So patient can try and become successful with this. So prefer SSRIs, monitor these patients closely. If there is a chronic pain, then perhaps duloxetine, amitriptyline or nortriptyline would be more suitable. If there is a problem with the patient preference or dosing convenient, once daily dosing options can also be chosen. Escitalopram is given once daily. So, and particularly, but provide education about delayed onset. Then you may consider, as I said, switching to another. It could be because of the lack of efficacy, but if you don't find, it should be done only after 4 to 6 weeks of adequate dosing. Don't do it immediately. If there is a partial response, that means less than 50% improvement, then dose optimization, then again you can consider switch. If there are intolerable side effects like persistent nausea, sexual dysfunction, insomnia, and weight gain, you have to switch. Then again, patient factors like other drugs being taken, or the pregnancy, elderly, cost, preferences, and if there is a history of previous good response, prefer this agent that worked in the past, or for a first degree relative, they are more likely to respond. So I think I'll switch this. But whenever you are switching from one antidepressant to another, watch for serotonin syndrome, discontinuation symptoms, start low dose of new agent and titrate it up gradually. Similarly, antipsychotics, if you know the adverse drug reactions, you can manage them properly, and you can treat at your level itself. Extrapyramidal symptoms are the ones which are very common, which includes tremors, rigidity, and dystonia. These are were more common with haloperidol, but risperidone in low dose. So try hexafenadil. This is an anticholinergic agent that you give for first few short-term use for first 2 to 3 weeks, and then this can be gradually withdrawn, and or you may have to switch to atypical one, Qutipin or clozapine. But now one major problem that we see most of the time, these antipsychotic and this trihexyphenidyl is started together, and patient remains on both antipsychotic and anticholinergic for the duration of treatment. This is for initial phase only. One should attempt reduction of this. Then sedation, weight gain, you have to focus on the lifestyle management, monitoring, and switching to drugs which have less impact on metabolic, like aripiprazole. Then constipation is another common side effect, which is usually ignored. We don't even ask for it, and these patients then are put on laxative, and they continue taking this laxative for a long time. Focus on adequate hydration and fiber replacement in the diet, or you can use osmotic agent lactulose if there is a lot of constipation is a big problem. So again, like with antidepressant, depending on the diagnosis, depending on the side effect profile, these are selected. Sedation needs, then comorbid medical illnesses. If there is a diabetes or obesity, avoid olanzapine and clozapine. Of course, primary care level will not be used. It is used only at a tertiary care level because it requires blood monitoring here. And then clozapine, I think I can. Route of administration, if you are concerned about adherence to the medication, is a big issue with the patients with schizophrenia who are on antipsychotic. There are long-acting injectables, whichever, but these should be started by a psychiatrist only. I will skip this long-acting injectable antipsychotics because there are various. This is also again to be done properly. But you can again consider switching from one group of antipsychotic to another if there is no improvement in positive symptoms after 4 to 6 weeks, and if there is ADR burden is high, again adherence issue, you can because of sedation, weight gain, then you can switch to another. I think but when you are switching, be careful about relapse or rebound psychosis. Avoid polypharmacy unless supervised by psychiatry. Consider anticholinergic load if combining during cross taper. Monitor weight, BP, glucose, lipids before and after. Generally, again, always reassess if the patient is not responding to a drug. Always reassess diagnosis and adherence. This is a major issue before switching, before saying that this person is not responding, and try to document the reason for switch and discuss with the patient. So again, time to benefit. Educate the patient about time to benefit. If they know, if you can handle their expectations, then you can manage these properly. But if they are expecting a quick relief, perhaps these are the drugs which need has a delayed onset of action. So if you educate them about the side effect profile, tapering has to be done slowly, gradually. So refer to psychiatry if there are multiple failed trials, if there is a complex polypharmacy, or there are severe side effects, or when you feel that you need. Always, when as a general practice, I think clinical tips are start slow, low, and go slow. Monitoring, cross titration. So this is my last slide. The role of GP is that first contact, if the patient is coming, because most of the time they will come to you, have to screen. They may come up with the non-specific symptoms like fatigue, insomnia, poor appetite, headache, or vague body pains that may mask underlying mental health issues. So you have to be keeping these in mind, and then you may have to initiate the treatment also. So psychoeducation about the nature of illness, expected course, importance of adherence. Then non-pharmacological treatment techniques, interventions are equally important. Sometimes they are not replacement for the medical therapy. Many times people give a prolonged, protracted trials with the non-pharmacological interventions. But these sleep hygiene, particularly if patient is having insomnia, or structured routines, this can help. Then monitor and modification, referral when needed, and continuity. You act as a continuity provider, so ensure long-term care and relapse prevention. People cannot be treated all the time at a tertiary care level because this treatment is prolonged for many months, and some may need it for years together. So unless you have involvement of the family, coordination with the community mental health services, the success with the treatment becomes difficult. So and also as a mental health advocate, you need to destigmatize and promote mental well-being. And this doesn't only start with your clinic or your primary health care or dispensary or a hospital. You need to start in your school, with the schools, workplaces. You need to educate them about these, how to maintain a good mental health. Because if you stresses, what are the stressors, how do you maintain, this should begin early in the schools and workplaces before it becomes a full blown disorder. I think I'll stop here. If there are any questions, we can take this. Dr. Tanmay is here. I think there were 1 or 2 questions which we could not take it earlier. This was about suicidal risk in alcohol, alcoholics. I think that was the question.
Sorry, ma'am, didn't get the question.
Yeah, let me just go back. I think
Ma'am, it was about suicidal risk in a patient of alcoholic or substance abuse.
Okay. So the basic dictum is let the person wean off the substance, spend some time off the substance before initiating any intervention per se. So all that we can do while the patient has been consuming substance and just recently been in the acute withdrawal phase is to ensure safety, make sure there is no access to any lethal weapons or lethal objects that one may use to harm themselves. All the medications have to be supervised. The patient has to be in 24/7 supervision. Like Bhavuk sir had said, you need to make a anti-suicide pact and involve and activate all measures that you can to keep the patient safe. Because a lot of times, all of these thoughts are induced due to the substance as well. Some people may have pre-existing illnesses, and some people may have exacerbation of their thoughts when they are under influence. So it's a little, what do we say, dynamic. You need to keep the person under supervision. That's the best approach. So never try to treat them on outpatient basis unless and until you can mobilize family members. If there is no social support, try to keep them under your supervision.
there is another, I think you can take this. Hypoglycemia can cause panic disorder symptom. Can an eating disorder simulate panic disorder?
So eating disorders are a known differential diagnosis for anxiety disorders. So yes, eating disorder can mimic panic disorder as well. The short answer is yes.
Hypoglycemia, hypoglycemia and other organic causes like pheochromocytoma, they may mimic panic disorder. So you have to make this assessment when the patient presents for the first time, at that time, but once the patient is diagnosed, how does this history, this one, diabetes or pheochromocytoma would be influencing the course of panic disorders?
So basically, treatment of the primary condition is the mainstay of treatment. Sometimes when the primary condition is not improving, you may have to initiate treatment for the psychiatric disorder as well. But always and always keep a track of what the primary condition is and what the progress of the primary condition is. That is always supposed to be done. Likewise, for hypothyroidism, depression, diabetes, depression, you need to have concurrent treatments at times, but always take care what the primary diagnosis is in the state.
Okay, sometimes they get labeled, there are more chances of, first time at least, initially when the diagnosis is not made, especially I know pheochromocytoma, it is a hit and run type of a disease. Here, episodic hypertension would be there, and it would look like a bout of sweating or panic or headache. It looks like panic disorder, but carefully assess, otherwise these patients get wrongly labeled as panic. On the other hand, panic disorders, they are investigated, उनका investigation ही चलता रहता है to find out the cause. So you have to have a balance here. Then there is a question about treatment of early dementia in diabetic elderly.
Right. So early dementia, again, cognitive assessment is something that is within your armamentarium of any assessment. So first of all, go by age. Age-wise, if you're having memory disturbances, bedside screening, short screeners like MMSE, HMSE, MOCA, Montreal Cognitive Assessment, and many mental status examination, Hindi mental status examinations, these should be your armamentarium till someone is not grossly giving you a very low score on all of these, like 23 से कम नहीं हो रहा है, 25 से कम नहीं हो रहा है, तब तक तो there's nothing. But early dementia है, then always rule out pseudo dementia, any depressive features, and if at all you find out that the cognitive decline is very rapid and very rapidly progressing, involve neurologists to rule out any organic causes. If it is very gradually progressing and very easy and subtle, then routine care of dementia. You may have to then reinstate all the anticholinesterases, etc.
Sometimes, these elderly patients, they present with some psychiatric behavioral issues. can you just briefly tell the participants, how do they manage these patients?
So the behavioral variants of dementia-related diseases, like we're talking more about frontotemporal dementia, where they do not have as much cognitive decline as much as they have behavioral issues. So they'll have anger outbursts, they'll not listen, they'll soil their clothes, they will have some organic pointers. There's no one test to know all of this, but management is purely behavioral and psychological. We call them behavioral and psychological symptoms of dementia. So all you have to do is take more care. You appoint a healthcare provider. Sometimes just to maintain the circadian rhythms, you may have to give some drugs so that the circadian rhythm is maintained. Some behavioral control may be acquired by using mood stabilizers. They may also be having concomitant seizures due to decreased intake, electrolyte imbalances. You need to work up for that. And comorbidities may be there, like diabetes, hypertension, rule that out. But majorly psychiatric drugs are not involved in all of this because no drug has been found to be
I've
very
seen
effective.
quetiapine being prescribed.
All very low doses, man. All very low doses, only to
25
maintain the
milligram,
circadian
maybe
rhythm.
just 25 milligram, very low dose.
Only for sleep disturbances, man. So that they sleep at night. They sleep well at night, only for that purpose. And a little bit of behavioral controls. Quetiapine, aripiprazole, these are agents. Sometimes we use some more agents, but majorly quetiapine because EPS risk is very low.
I think caregiver, counseling and
Education,
education
expectation
is very, very
management.
important.
We need to manage
Because,
the expectations also for the caregivers.
yeah, a lot of
They
time,
may expect dramatic
even
improvement.
well-read, highly educated people, they expect that there is some cure for this dementia, so you need to.
Everyone is in denial to begin with.
Yeah.
We need to
Okay,
very
there is,
sensitively.
I think, one question about why the mental disorders are called so. Are they different from mental illness?
So illness and disorder, and there's a very clear demarcation. You find a root cause. There are some principles of an illness, Fox postulate. You find a cause. If you put that cause into someone, it should be able to give rise to all the set of symptoms. Remove the cause, set of symptoms should vanish, and so forth and so forth. Mental disorders do not have one cause. It's a multifactorial thing, like all the other metabolic disorders as well. Diabetes also does not have one, cancer does not have one. So all of these are disorders. Illness, the day you have an etiology, you'll have an illness. So disease is if you have an etiology, disorder is when you don't have one etiology. So that's
The nomenclature is like this, syndrome, we
so
use
we are
the
going
word.
syndromally. All the medical disorders actually went from syndrome to diseases only. Right now we are at this stage.
I think we are done with the questions, and today it's already 6 o'clock, and it's a huge topic. There may be, there is a question: escitalopram better to give morning or night?
That's one molecule you can give at any point of time. It has no preponderance.
Once a day is the dosing, and it depends on the patient's tolerance. Whatever they say, they can do it. Sometimes. If they are finding it sedating, then you can use it at night or depending on that. Okay, I think this is a huge topic which will go on, and I hope some of the, you got the answers, and you will be able to identify these common disorders at a primary and secondary level of healthcare and treat these patients. At our hospital, we see there is so much of patients coming directly to the tertiary care, which can be avoided if these are dealt at the primary care and secondary care level. And as I think Tanmay will endorse this, जितना ज़्यादा severity हो जाता है, it becomes difficult to treat.
Absolutely.
जितना लंबा duration symptoms का रहता है, it becomes difficult to treat. So if they are
Absolutely.
identified early and they are treated early, you can manage these patients and they can live almost normal. They can fit very well into their families, their work environment. But only when, because many times we just keep saying, isi ek baat pe isko problem hoti hai, baki sab to theek hai. There is a denial in the family. How do you deal with this? Ek hi problem hai bas iski.
Education. Education is key.
Yeah,
Because we
see,
need to
if it
move
is,
everyone.
बाकी सब काम तो I keep hearing, तुम पहले क्यों नहीं लेके आए? नहीं, बाकी तो सब ठीक चल रहा था, बस इस एक बात की प्रॉब्लम तो थी, तो we thought that this is normal. So I think हमारे को थोड़ा सा tolerance of this level कम रखना चाहिए. मटरिंग कर रहा है, गुस्सा कर रहा है, घर में पेरेंट्स को उसको मारपीट कर रहा है. These are signals that this child has a problem, and you should take them to a formal healthcare system where they can be diagnosed and treated. हमारे यहाँ सोसाइटी में जब तक वो अपनी सेल्फ केयर नहीं छोड़ देता ना, जब तक वो नहाने धोना खाना पीना बंद नहीं कर देता या सड़कों पे घूमना नहीं शुरू कर देता, तब तक उसको इलनेस नहीं मानते हैं. तो आई थिंक if you know that you can educate people, identify such people and motivate them to take the treatment.
Absolutely. Duration of untreated illness is the single most modifiable factor that we can do as professionals by being more aware of the symptoms, early identification, and then referring them to treatment or initiating treatment.
अभी एक क्वेश्चन है, many symptoms of severe depression and psychosis look similar. How do we differentiate?
So basically, at primary care level, if you find any set of symptoms, it's not your primary job to differentiate between both. Look at what the level of dysfunction is. And depression versus psychosis. Psychosis is grossly an impairment of reality. When a person actually loses touch with reality, that is when psychosis seems to have taken over. So in severer end of depression also, they may have some psychotic symptoms. And if there is primary psychosis, तो शुरुआत से ही लक्षण वैसे मिलेंगे. So primary psychosis versus severe depression has a chronic course. It does not develop over 1 day or 2 days. Psychosis, on the other hand, can develop in a very short amount of time. So duration is one thing. Second thing, how much of a departure is it from the original personality? Depression usually has the personality intact, but psychosis usually disintegrates the whole personality of a person. Depression में functionality is affected relatively later. Psychosis में functionality बहुत जल्दी impair होना, affect होना शुरू कर देती है. Content of the thought, that changes a lot in psychosis. But there are certain delusions that set in, there are some misinterpretations that set in. Depression mein, it's more of like lessening of everything. There's a diminished affect, diminished behavior, diminished thinking abilities. Psychosis, on the other hand, a person will not diminish in his capacities, he will just deviate in his capacities. So these are major pointers. The psychosis कहाँ है और severe depression कहाँ है. बाकी कुछ चीजें तो समय देने के बाद ही समझ में आती हैं. Usually, difficult cases require time.
डॉक्टर में एक और मैंने चीज देखी है, when you have not made the diagnosis, तो दोनों दे देते हैं, एंटी डिप्रेसेंट भी दे देते हैं, एंटी साइकोटिक भी दे देते हैं. How far is that good? How that practice is good?
We usually don't endorse it, man, because we don't endorse it.
Yeah.
We don't endorse it because we believe.
Also, don't use the fixed dose combination. उसमें they will put antidepressant, antipsychotic, anticholinergic. Sometimes I have once seen उसमें benzodiazepine भी था.
Right, man. There are some companies who are manufactured.
Some of them have now been banned, but don't use these. If at all needed, you can add it. If you feel that there is some psychotic component, you can add this, but don't use a fixed dose combination. Then you will never come to know what was the diagnosis in this patient.
And a person should be reliably able to distinguish between the set of symptoms at primary care. You just read and you keep seeing patients, you will gain that confidence to reliably say this is an affective disorder versus this is a psychotic disorder. You will be able to say that. Because
How do you
when you talk to the patient,
Yeah. How do you convince patient? You know, you have a psychosis wala patient. Generally, their adherence with the treatment is poor because of denial or lack of insight. How do you convince them?
So, ma'am, basically we talk to the patient and we try to hunt for that one thing a patient wants a change about. Sometimes it may be, the critical comment, sometimes it may be this, sometimes it may be that, and then we make medication as the agent of that change. So a person says कि ताकत थोड़ी सी आ जाए, ये वाली दवाई खाओ, इससे ताकत अच्छी आएगी. That is the initial. One thing that we avoid is no surreptitious medications, because then the trust starts to break down. Family members are advised not to give it under the cover of some other thing, under the guise of anything else, because that leads to a lot of trust deficit. So we don't advocate surreptitious medications. We say देना तो है, context बदल के दे सकते हैं. वो दवाई अंदर जाए that.
How about
Covert.
covert use?
That's what, ma'am. Surreptitious covert use, we don't advocate that. That's why we try to
Another
gain
thing
common
is,
ground
you
by
know, these
talking.
patient would say कि मैं तो इतनी देर से treatment ले रहा हूँ, इसको discontinue कर दो. So how do you maintain
So
that?
we always say, ma'am, that we understand it's been a long time and treatment has been going on. But now that you're here and I've interviewed you, I think there are still some actionable points. I believe there is more improvement possible. I believe if you have some concerns regarding medications, I'm ready to modify the medications in that sense. But I believe medications are absolutely necessary for you. That is my point. Now that you know it's absolutely necessary, whether you take it or not take it is your responsibility. But my job is to make you aware that you have some set of symptoms that mandate you being on medications. These are the medications in such a dose that you may not encounter the adverse effects. Try, take, and you will benefit. We are here for any other changes that you need.
I think we're done with it. Today's session, it's already beyond 6. Thank you, Tanmay.
Thank you
I
so
think
much.
Bhavuk has left, but we thank him also. We can close the session, Aman.
Thank you, ma'am. First of all, thank you, Tanmay sir, for your informative session. And with this, I would like to inform that we have already shared the link to the post test in the chat box. We've already shared a link for the feedback where you can suggest how was the sessions and what more sessions you may require in the upcoming sessions and the series. Also, we have shared the link to the QPS YouTube channel where you can find previous sessions as well as this session will be uploaded on our YouTube channel within like next week. With this, I would like to thank.
Next session would be on 21st June.
It will be on 21st June, and the topics for the next session is management of acute sinusitis and management of epistaxis in the primary healthcare settings. Hope to see all the participants next time as well, and I would like to thank all the panelists, our advisors, sir, our executive director, sir, Sangeeta ma'am, and both our esteemed guest faculties, Dr. Bhavuk Garg and Dr. Tanmay Joshi. And thanks to all the participants. Thank you so much.
Yes.
Thank you so much. Thank you so much.